So I'm gone. All right. Good morning, everybody, once again.
Good
Um,
morning.
Good
I hope
morning.
everybody is doing well. Um, Today is April 1st. We begin our med aid training, and it's a 3 days class. So let me introduce myself once again. My name is Rosalind Abankwa, and I am a nurse educator, and I've been in the healthcare space for 21 years now. I've been in the 21 years, I've been a nurse, 16 years of that 21 years in the healthcare space. And I built my way up from being a caregiver, being a CNA. I went to LPN school, got my RN, got my BSN, got my first master's in education, nursing education. I'm doing my second master's in psychiatric nurse practitioner and also doing my doctorate in nursing all at the same time. So I got my hands full with education. And I want to welcome you all. Um, I want everybody to introduce themselves to me again, even though I've met you all before. I want to know your background, where you're coming from, and why this class. What are you taking it? Why do you need this medication aid class? I would like to know before we do the next housekeeping activity.
Hey, hello. My name is Tina Halleck. I'm doing your class for Hope Harbor Personal Home, which you have so. I'm losing my train of thought. Sorry. I already done my PCNA through you, a class which I really enjoyed. I did about 12 years of CNA in the state of Georgia, and I moved up here.
Okay.
Um, so now I'm wanting to get back renewed with everything and go a little bit farther with it.
Okay. Nice to meet you, Miss Tina. All right. Our next student, if you want to
My name,
introduce yourself to us.
my name is Jamie Johnson. I apologize for the camera. But I am too taking this course to become an employee with Hope Harbor. Um, I am normally an administrator, working in administration. Um, However, some years ago, I owned my very own independent home care. So this is not new to me, but it is because there are some facets to it in the state of California. It's different than here in North Carolina. I, just like Tina, have had Miss Roslyn as our trainer, and we have thoroughly enjoyed going through the PCA course, and now we are here for the final leg. And thank you so much for your time that you have given to us, because I know that you are a very busy lady, obviously.
All right. Well, good to see you all again, and hopefully to see you on the third day for the skills checkoff, which is the icing of the cake, because everything is crowned with the skills. And when everything is checked off on your skills document, then it means, as a nurse educator, I'm trusting you that a patient is going to be safe with you giving them medication. So it's a big deal. It's a great deal, not just a big deal. It's a great deal because the state of North Carolina, the DHSR department, to be specific, see me as a competent nurse who has gone through vigorous training over the years and trust my judgment to teach another person to do medication aid. So they know that if I issue a certificate to Lady Jamie or Lady Tina, then it means I have done the due diligence of giving the best training, every information, every detail that you all need to know to be able to be a safe, med aid, so that patients left in your care will not die. I want to use the word die because that's the ultimatum. If someone dies, that's the big thing, is the biggest. And every other leg in the state and the family and the whole 9 yards will be involved. So med aid training is something that is very dear to me, because even though I teach other classes like CPR and everything, which is also saving life, this one is it's a long-term thing for the person, because you're going to be with the person for however many months and weeks, months, and years, that you'll be working with patients. So it is a great deal. And I want everybody to see it as that. All right. So quick housekeeping thing. So today being the first day, we're going to go through the theoretical aspect of medication training. So the time is 9:14 right now. As we start, I'm going to give break maybe an hour and a half if you want to stretch your leg, if you want to get water. I mean, do something 10-15 minutes, then we come back, because I don't want it to be boring. I don't want to bore you looking at slides and all that. But it's important we get the foundation right. So after today, tomorrow we will watch the video of what the state has given to us, how they did the medication administration. So we will watch the video tomorrow, go over what we've learned today, and then the last day we will meet in the lab, and then we will see all the stuff that, well, some of them are pretend medication stuff, because some of them are candies and all that, but we are going to use it to simulate that you are with a patient, you are going to give them their medicine, the do's and the don'ts, everything that we've learned within this classroom. We're going to now put it into practice. Then I will mark everybody off. There is a form that I have to meet the facility administrator, and then I will mark it off that, hey, this person has taken the training, they've been in the skills lab, they've done everything right, they are good to pass medication in your facility. So I'll mark it off, they will mark it off, they will keep it in your record as an employee, they'll keep it in your record, so that when the state comes around and they check the employee records. Why is this person passing medication? There is a proof inside their records that says that they've gone through an approved training and they qualify, or they are competent enough to do what? To pass medication. So the state will not be on the neck of the administrator. Shut the worst thing they will do, they can shut the building down, because if they are using incompetent people or those who are not qualified or have been approved by the state, then it means you are causing danger to an individual, and that's a big deal. They can take their license from them and shut the building down, and we don't want that to happen. That's why they need to go through all the process, do the right thing, get approved that I am qualified to pass medication. So I'm going to share my screen, and then we will share screen. I'm, I'm not a big fan of using Zoom to teach. So if any technical challenges come, please bear with me. It's going to get better as we. So I would like everybody to be muted so that no other background noise will come into the recording because it is going to be used later. And as I talk about things, if you have questions, please write it down. Then there is a hand on the Zoom thing that you can raise your hand. If you raise your hand maybe a minute and I'm not seeing it, you can unmute your mic and say, Miss Roslyn, I have a question. And then I would pause and I will answer the question. I want to lecture for a minute or two before. So at least maybe the question may be answered as I keep talking. But if I keep talking for a while and whatever is in your mind is not answered, then raise your hands. I will see it. I should be able to see it. And then we'll go on to your question and answer that. All right. So you're welcome. Now, this class is the 15-hour administration class. The 15-hour. They have the 5 hours, they have the 10. This is the 15. So what's the difference? So the 5 hour could be for someone who is already a med aide working in the nursing home. If they are working in a nursing home and they want to come and work in the adult care setting, the skilled nursing home, they have nurses that are supervising them. Okay, there are nurses that are there, LPNs are there, the RNs are there. But in the adult care home, there could be an administrator who is not a nurse. So that's why there's a slight difference. There are things that the med aide who works in an adult care home, like an assisted living, a family care home, a group home, an independent living, all those are called the adult care homes. There are skills that a med aide there can do that is not permitted in the skilled nursing home. I'm not here to teach the skilled nursing home med aide, which I'm also an instructor for, but I'm teaching the one that is for the adult care home. So one of the differences is that as a med aide working in an adult care home, you'll be able to you'll be able to do glucose check, which is also called sugar check, and you'll be able to give insulin. Those working in the nursing home, they will not be able to do that because they have the LPNs there, they have the RNs there. Okay, so that's one of the differences. And as we go along, you'll see. All right. So this is an approved North Carolina DHSR 15-hour requirement for the medication aid training in the adult care homes. So today we're gonna go over, they have categorized the lectures from sections A up to K. The state gave us all these sections, so we're gonna go over all the sections. So this course meets that mandatory requirements. It's a 15-hour. So it focuses on safety, documentation, legal compliance. What else? We're gonna also go over the fundamentals of medication administration, legal and ethical responsibilities, infection control, and then we will do the competency validations. So the sections go over, like I said, A to K, and we do the skills, and then we will look at medication aid role, the legal and ethical, medication administration, the overview of everything, orders, and the MAR, which is the medication administration record book. We will have a look at how it looks like and how you're gonna fill it. After you give medicine, you are supposed to document. And what are you documenting on? It's called MAR, Medication Administration Record Book. How to use that MAR Then we're going to touch on infection control. Now, infection control is a course on its own. The state, the DHSR department, has a course, an infection control course. Is a big course on its own. Now, what I'm going to do is that I'm going to upload that course on my PayHip, just as you took the PCA training. I'm going to upload that on PayHip. Even though today we're going to touch on it, but it's not the full course. This is just the introductory part. I'm going to put the full course on the PayHip, and I will give you maybe a week or two later, I'll give you access to it. I want you to be able to access that course and also learn. I want all of you to be fully equipped as you work in the adult care setting and know exactly what the state requires of every caregiver in the adult care setting. So we're going to look at, when we come to the lab, we will see the supplies and then how to store, how to order, how to dispose of medication. If it expired, I mean, you can't be giving expired medication. You will need to be able to tell the administrator that, hey, this thing has expired. Okay. So what is the prerequisites for this course? For someone to be a med aid, they should be able to know how to do vital signs. They should be able to know how to do glucose monitoring, basic clinical verification, which we're gonna go over. So I know that the vital signs part, you all learn it in the PCA course, which I'm very happy we were able to do that part. However, we will do a refresher when we meet in the lab. So I will have you do the blood pressure, the pulse, the respiration, the temperature, so that we know that it is still fresh in your memory, and you know that when you go into work, you are supposed to take your patient's vital signs once a shift. The vital signs taking helps you to know the baseline health of your patient or your residents. So it's not only observing the patient, which is the number one skill that everybody should have, observation from head to toe. You'll be able to observe to know their facial expression when you touch them, the body is hot. These are all signs, but an objective skill that every PCA, every med aid has to have is to be able to take your vital signs and do your glucose monitoring. That is, if that resident is diabetic. So the glucose monitoring, we didn't learn it in the PCA training. And so it's something that we're going to do in the lab when we meet it for skills. We're gonna do the finger pricking. So everybody's gonna do the finger pricking. You're gonna prick, you can poke your own self and see. And this is done so you know how to do it gently and be sensitive that, hey, as you did it in the lab and you pricked yourself, how it felt. When you are doing it on a resident, you'll be gentle, because I've seen people do it too hard, and resident will be screaming, and sometimes they don't even want to give you their finger for you to prick, because some people are so insensitive, So if you do it to yourself and you see how it felt, then it will be a reminder for you that, hey, I felt that poking. Even though I need to poke and get blood and see how much sugar is in the bloodstream so that he or she can get insulin, I need to be gentle about it. So it's very, very important. So we want all our med aids to know their blood pressure, pulse, respiration, temperature, how to use the glucometers. Now, every facility is going to be different. Okay, they have different, all kinds of glucometer. So whatever you see in my lab, the skills, it doesn't mean that's the same thing you're going to see in the facility. However, as long as you know how to use one glucometer, you should be able to know how to use the others, because they all kind of look similar. So you should be able to know how to use their glucometer as well. So infection control, everything we are going to make sure that we know. All right. So we are going to look at the med aid role, the medication administration role. All right. So we've just spoke about. So section A is what I just spoke about. Is the prerequisites to the whole class. You should be able to know how to do your blood pressure, your temperature, your pulse, your respirations, your everything that involves vital signs. You should be able to know, and also you should be able to know glucose monitoring, which we are all going to learn in the lab. And then it says that you should know the infection control course. So since you have not taken the infection control course, like I said, I'm going to give you access to it maybe in a week time. So you have that also. But we're going to talk about it in this section. All right. So let's go to section B. All right. So we're going to see, what is your role as a med aid? What is your role? What do you need to understand? Your responsibility. Now, every facility may vary slightly. So it is important that as a med role, as a med aid, you know your role and your responsibilities in the facility where you are employed. What are your expectations? What are your limitations? You need to know. How would you know? During orientation, the facility goes through a bunch of paperwork, where it says your job description. It is very, very crucial that as a med role, you read your job description. So in the adult care facility, you may be in two roles in one person. You are working as a PCA and as a med tech or a med aid. These are two diverse roles. I repeat, these are two diverse roles. A PCA, like you all have learned from the other course, no, they are doing the basic caregiving, okay? Helping the resident with the activities of daily living, observing things, reporting it, and everything. Now, when they add med aid to your job description, it means other responsibilities has been added to it. So understand your PCA role and understand your med aid role. So what is your role as a med aid? There's a general role stated by the state of North Carolina. So based on the need to provide safe care to the public, so statewide uniform standards were developed for the training and competency for all medication aides that are involved in giving medicine or drugs to residents in the adult care home. So the training for administration of medication that are provided in this course, it prepares you in the basic level how to administer medication. All right. So each adult care home has their own policies and procedures that everybody has to follow. Some of them have a very broad, description. Some of them are also stringent. You just have to understand that, hey, I'm working with Hope Harbor, I'm working with Facility B. This is what they have given, these are what they've given me, that my capacity reach. Okay. So administer medications to residents as ordered by their physician or the prescribing practitioner under the direction of the facility supervisor and the administrator. That is number one expectation of a med role, a med aid. I'm going to repeat it again. You are going to administer, in other words, you're going to give medication to the residents under your care. And these medications have been ordered by that resident's physician or the prescribing practitioner. So, who is a prescribing practitioner? One prescribing practitioner is the nurse practitioners. Okay, so like me, I'm in school to do my psychiatric nurse practitioner. By September, when I'm done, God willing, when I'm done with school and I pass my board, I will be prescribing medication to my psychiatric patients. So I will be a prescribing practitioner. I'm not a full-blown physician, but I'm a prescribing practitioner according to my licensure. So you need to understand both roles. And as long as they are prescribing practitioner, they have the authority to prescribe medications. And we nurses and med aides, med techs, we go according to the orders that these physicians and these practitioners have given in the book that is called Medication Administration Record Book, MAR. So I'm going to be using the word MAR a lot. And I want you to understand that it means Medication Administration Record Book. All right. So another expectation is that you administer the medications in accordance with established medication administration standards. So there are standards, and they are all found in the MAR. So you do it according to the policies, procedures, and practices of the facility where you are going to be working. And then according to the requirements of the state of North Carolina. You are expected to respect residents' rights to confidentiality and privacy regarding their health status, diagnosis of illness, medications. You will only share their information confidentially within the healthcare team in the facility and to those who need to know such information. So if there's two PCAs in the building, one is a med aid, the other is just a PCA, they are not a med aid, and they are asking you, oh, what medicine are you giving to Mrs. Joey? No, she doesn't need to know what medicine you are giving to Mrs. Joey. She's not a med aid. She is not going to be administering any medication to Mrs. Joey. She has no need for that information. Don't give it to him or her. That's what this means. The client has every right to be respected in that way. Don't share information to people who have no business in knowing. It's against the law. HIPAA is what they call it. So as you come on board to the field of giving medicines to patients, always remember, you only share medication information, all this information with another med aid, which you know that person is going to also what? Administer medication. But the other person who is not in the field of administering medication and has no certificate, they have no business knowing. If Miss Joey, a family member who is not listed inside their book, the residence record book, that they can have access to their information called, hey, I'm calling to check on my sister, my grandma, medicine. And who are you again? They tell you their name. Okay, give me a second. You go and check. Their name is not listed as somebody who need to have information. You tell them, I'm sorry, I can't tell you anything because your name is not in the record book. It's as simple as that. The patient has to be respected in that way. So it is expected of you as a medic to remember this. Only share protected health information with those who need to know to work with that person, that resident directly. You are also expected to follow the facility's standards in hand hygiene and infection control. So every facility has their policy and procedure about hand hygiene, standard precautions, blood glucose monitoring. It is very important that you follow. So, like example, the blood glucose monitoring. If it tells you that if Miss Joey, their sugar is 98, that's a low blood sugar thing. So this is what you have to do. If the numbers are below this range, this is what you do. If the numbers are above this, call the resident physician or call the administrator. You must follow that standard precautions that has been said, those policies and procedure. If you don't follow, then the consequences of it will be very detrimental to the health of that resident. So you're expected to follow that. All right. Also, a medication aide must follow the 6 rights of medication administration. Now, throughout the entire course, the 3 days, you're going to hear me repeat the 6 rights like 10 gazillion times. So don't let it bore you because the state want us to screw that into everybody's mind so that there is a high chance that when you work with the resident for some time, you can forget like, oh, I don't need to go through all these things right every time. But you must always remember, it must be second nature to you. So the right resident, right medication, right dose, the right route, the right time, and right documentation. We're going to repeat it and repeat it and repeat it until you cannot forget anymore. So always use the medication administration record, which is the MAR. I've already said that. When administering the medications, and compare the information for medication administration on the MAR to the one that you see on the drug container, the label. If it is different, then you have to let your supervisor know. You have to let the administrator know. If the label is saying give 5 ml, however, your MAR book is saying give 0.5 ml. That's a huge difference. Don't go ahead and say, well, the label says this, so let me go ahead and give it. Don't do that. Don't do that. The pharmacy that brings this book, this medication book, and then the medicine itself, they are humans, and sometimes errors happen. Okay, so we are the final eye until that medicine enters the person's mouth. We are the last straw to do the last check before they take that medicine that could kill them, that could put them in a very worse condition. So it is very crucial that you know that you've done all the checking that there is to. Seek advice from supervisor, the doctor, before giving medication to the resident anytime something unusual occurs. So example, if the resident is too drowsy to take medication, if the resident is vomiting, if the resident cannot swallow well, you need to let supervisor know. If you are the supervisor in charge, you need to let the administrator know. And you need to call the nurse practitioner or the physician. Let them know, hey, Miss Joey is no longer able to swallow her medicines because as they age, as the days and the weeks progresses, these residents, they have change in condition. So at some point, they were able to swallow their medicines, all right. Then a month or two will come along the line and they can't swallow anymore. We can't force it down their throat. So you need to let them know the change in condition as soon as practical. You tell the supervisor, or if you are the supervisor in charge, you tell the administrator, hey, I think something is wrong with this lady. She can no longer swallow. When she swallows, it looks like she's choking on the medicine. She's coughing vigorously. So you are the last eye, like I said. And when you observe that, you let them know, you call the doctor. Because if it's in the policy for you to call the doctor right away, do that. But if he says that, call the administrator first, do that. Always follow the chain in command. Don't bypass your administrator and go call physician when the policy and procedure said call administrator first. He might be not in good terms with that administrator because they always might want to be the one to know first. And then they can advise you and direct you what next to do. So don't bypass the protocol, the hierarchy in the facility where you work to do anything. Please always follow. If they orientated you and told you that if this and this and that happen, call supervisor, call this person, call that person. Please follow that to keep the facility safe. Unless it's in a high case of abuse, that calling the administrator, you know that they are aware of it and you've reported it severally and they didn't do anything, then you go above them because of the resident safety. So let's understand the two sides of it. So you seek advice when someone who is too drowsy, how would the person take more medicine? Because some medications can keep them in a drowsy state. We'll go through all that. Okay, so if whatever they took is causing them more drowsiness, doctor can say, hold that medicine, and you need to document that it was held per MD's order. You have to do the right documentation while you are holding the medicine. Patient or the resident has been throwing up all morning. Why would you want to give medicine? They will throw up that medicine, and it would have been a wasted medicine. And these medications cost them thousands of dollars. Why would you want to waste their money? So call the supervisor, call the administrator, follow the protocol, hold the medicine and put the reason, whatever reason they have given you to hold. You put it in the right documentation. You do that. It's very important. So after medications are administered correctly, you have to document the medications have been taken. Don't document before you give it. And people do that. Okay, they will mark something they've not given. They mark what they have not given. I have caught so many errors over the years. Nurses do that. Nurses do that. Med aids, when they've been in the system for far too long, they tend to do whatever. Familiarity breeds contempt. they tend to do all sort of things. Please, as you all come into the field of medication administration, don't do that. Don't document before you give it. After you are done giving it, then document. Because if you document and the person doesn't take it, then what? That's an error. So don't do that. So maintain, is expected of a med aid to maintain security of medication cabinets. So all facilities, every facility you work, they will have the medication cart. In the hospital, we call it the cow. Okay, they call it the cow. We wheel it around. All the facilities also have the adult care homes and the nursing home. Their cart is very heavy. In the hospitals, ours is a little bit small. It's not that heavy. Yeah, even though pushing it around can be bad. You see the difference there. You have to keep it locked at all times. That's part of your role. Keep your med card locked at all times. I can't stress this enough. When you turn around and you are not locking it, somebody can come behind you and take something. And because you have taken the keys, you are responsible for the narcotic drugs and every count in it. So imagine going to the patient room, leaving the key there, not locking it, and you go. Someone come behind you and do what? Come in and take something. By the time you come out, you wouldn't know who took it. And if you are doing change of shift, you have to count all narcotics. And it has to match whatever it was with the previous shift. And if medicine go missing on your shift, guess what is going to happen? You can't be reported to the state. Your license, the worst thing is that you can lose that license you're going to get at the end of this course. So what is the essence of getting trained to lose the license? I always tell my coworkers, I work hard to get my nursing license, and I'm not going to lose it for anybody, for anything. I will not. So I'm going to count whatever needs to be counted, and you will not make something and give it to me to go and give it to another person. I will not do that because I didn't miss it. I don't know what is inside of it. This is a serious business. This is a serious thing. Okay, this is a very, very, very serious thing. I promise you, whatever stress you go through to take this course, by no means should you lose the license for any reason. The state can put you on the list of whatever name they call it, and no healthcare space is supposed to hire you. It's that of a big deal when they put you that because if a narcotic drug get missing, guess how they're gonna look at you? That you're a drug addict. You are the one taking the medicine. God forbid. Even when I'm very, very sick, I don't even like taking Tylenol. I don't like taking ibuprofen. How much more going to steal hydromorphone or morphine or oxycodone? What am I going to use it for? I hate drugs. I personally, I hate putting anything down my throat to swallow in the name of drugs, in the name of medicine. So I wouldn't want my license to be taken away from me because somebody came behind me and stole something, and now I'm being tagged for it. It is very, very important. I like to stress this part a lot. It is very, very important. Don't do it. Lock the cabinet at all times. Whenever you leave the work area, lock the cabinet and the car. Anything that has medicine with it, lock it, put the keys in your pocket. Hold on to it like your life depends on it. Hold on to it like your life depends on it. So follow specific facility policies and procedure regulations regarding handling, storage, disposal of medicines. You need to know if the resident did not take medications, document a clear explanation of why it was not administered. So example, if they were throwing up, they were vomiting, and you held the medicine, you need to document in the MAR. MAR. Recognize when a medication should not be given, such that when it is expired or it's not labeled correctly, the label is not readable. It is very important. If you can't read the label on that bottle, don't give it. Because you need to be able to verify what is on the label with what is on your MAR, on your MAR. Recognize that the unsafe conditions described above must be reported to the supervisor immediately. And like I said, if you are the supervisor in charge, then let the administrator know. It is your license on the line. So remember this. If all the lectures here is so boring and you didn't remember anything, let this key statement stick in your mind. The med aid is the last checkpoint before the resident takes the medication. And it's important safeguard for the resident to whom they are administering the medication. I'm going to repeat it one more time. This is the eyes of everything we are talking about today. You, as the med aid, you are the last checkpoint before a resident takes medication inside their mouth. And it is very important to safeguard that resident to whom you are administering this medication. Limitations of med aids. Med aid must be able to identify exactly what tasks the facility allow to perform and what tasks they are not allowed to do legally. Give me 1 second. I think I have a question. Let's look at the question here. Okay. So let's look at the question here. Could you touch on and clarify what it means? Respect decisions of residents who are able to make informed decisions about medications. Okay. All right. Yes, we're going to touch on that. We are going to touch on that. Okay. Okay. All right. I don't know if you can still see do you still see my screen still or not? Someone should respond. Unmute yourself and respond. I'm sharing my screen. Yes? Okay. All right. Okay. So you have to respect. Now, the resident you are taking care of, you have some that are alert and oriented ×4. Let me explain what that means. When a resident is alert and oriented ×4, it means they can tell you their name. They can tell you what time it is, who is the current president. They can tell you where they are, where they live. It means they are alert and oriented ×4. They have their intellect intact in there. They are not demented patients or residents. They don't have Alzheimer's stage 4, whereby they are confused completely. They don't know what they are doing. So when you have residents like that, you have to respect when they tell you, no, I don't want to take my medicine. When they say that, it means they are able to make informed decision. You must what? Respect that. Now, when they tell you they don't want to take medicine, you need to ask them, Miss Joey, why are you refusing your medicine today? You need to know. Whatever reasons they tell you, take it to the supervisor above you. Take it to the administrator if you are the supervisor. And let the resident physician know. And also you have to let their family, whoever is the direct authority, decision maker, know. Sometimes it will take that decision maker to come to that facility, to come and talk to the person before they will start taking their medicine or before they will take that medicine. Remember that. But you can't force someone who is alert and oriented times, even if they are alert and oriented time 2 to 3, even if they are confused and they are saying, no, I don't want it. You have to leave them alone for some time. Those who are super confused, leave them alone for some time. At that moment, they might be very upset. Leave them alone. Every facility will tell you how many times you can attempt. Because I've worked in a facility where we could attempt 2 times. And another facility I work, we attempted 3 times, according to our MAR policy that we were trained to do. Okay, so every facility is going to be different. So I can't give you a cut and dry thing that, okay, attempt it to or no. So go according to the policies and procedures that is in the facility. If they say that here in Hope Harbor, if a resident refuse, attempt it at a different times, 3 times, that's what you have to do. On the third attempt, and they said no, you have to document. You have to let the administrator know. You have to let the physician know and let their family members know. And like I said, sometimes it will take that family member to come and explain to them their grandma or their grandpa or their mama and come and talk to them and say, hey, mama, I was told you are not taking your medicine. And then they will be able to convince them to take the medicine. So that is what it means by you need to respect their decisions. If they are able to inform, do a well informed, they are with it. Yes. So you greet them, you introduce yourself. Good morning, Miss Joey. My name is Miss Roslyn. I'm going to be your med aide today. I have your medicine ready. So you check, you do all the verification you need to do, and then you bring your items closer to administer. We'll come to all those parts in the next sections. And they'll tell you, no, 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 no. If they are confused, if they are crying, if their facial expressions telling they are in pain, you need to find out more. So the good part is that when you are working in an adult care home, like the family care home, the maximum patients resident you have is 6. You have 6 residents, right? So with 6 residents, I mean, the one that is giving you hard time, you can leave them for the meantime and go and finish with those other ones who will just take it when you introduce yourself and give it to them. When you are done, then you make time for the one that is giving you, I call them my problem child, you know. So you go to that problem child, and then they are not children, but I'm just using that jargon. So you can make time for them, try to understand how they are feeling, what is making them come to that turn. That's what it means. And then you need to be able to report. You need to be able to report whatever it was that has happened, that, whether they took it, whether they didn't take it. If the resident asks questions about the medication, it is best for the med aide to refer the question to the supervisor, the primary physician, the prescribing practitioner, the registered nurse, or the pharmacist. You, as the med aide, you are not in the position to go in and explain their medicines to them, even if you may have the answer to. Okay, so how come I usually take an orange pill. Why is this one today it looks blue? Okay, get the administrator involved. Now, one reason why the medicine may be looking blue today is that sometimes, the facility can switch and change pharmacies, pharmaceutical companies. And what I have seen over the years as a nurse is that some pharmacies, the shape of the same levothyroxine or Synthroid pill, I've seen Synthroid pill looking white and some looking ash gray, and some having a different shape than the other. So the resident who is alert and oriented times 3, and know that in the mornings they take a gray looking Synthroid, and now you are bringing them a white looking Synthroid. Yes, I will question it if I was in their shoe and I'm with it. So always try to put yourself in their shoes. If you are the one in the bed and you always take a pink pill, and now they are giving you blue pill. Would you take it? Now, as a travel nurse, I worked in one of the facilities. I had one lady, and she knows the color, the shape, the the size, the weight of every pill she takes. I was surprised. And I loved her for that. I always want my residents or my patients to know what they are taking, honestly. Honestly, as a nurse, I always love the fact when a patient knows what they are taking, when they're able to question what you are giving them. It gives me joy to tell them, oh, you are taking your metazepam, it's for your depression. You are taking atorvastatin, it's for your cholesterol medicine. You are taking Tylenol, it's because you have pain. I love to do that. In fact, as an educator, for me, I love to run my mouth and explain things. Okay. Some nurses get very angry, and when they are giving you a report, they'll be like, oh, that patient wants you to explain from A to Z. She get on my nerves. No, it doesn't get on my nerves. Because one day I'm going to be an old person in that bed. And I want to know if I have my intellect intact. I want to know what you're giving me. I want to know what those young generation coming, what they are giving me. I don't want anybody to say, here's your pill, open your mouth. No, don't do that. I've had one lady say, ooh, back, go back. What are you trying to give me? And I'm like, here, this is your medicine. Okay, explain to me what is inside this cup. I said, okay. I went to grab another second cup, and then I started pulling it in. Now, sometimes it's not all the medicines that I know and know their shape, but some of them I've been in the nursing field enough to know that this, when I was pulling it, especially when they give me a report that that person likes medicine being explained to, I'll make sure I memorize every medicine I'm going to give to the person. I memorize the shape and tell this white one, this oval looking one is your atorvastatin. This blue one is your oxycodone. This one is the metazepam. This one is your Synthroid. This I'm being paid as a nurse. And so explaining to my resident and my patients what they are taking is part of my job. I hope everybody get that part. If there is something different about the resident or the medicine they are taking, talk to the supervisor, like I said. If the resident seems to be having difficulty because of medication, alert the supervisor immediately. Report any errors in the administering the medicine immediately to the supervisor or the primary physician. And like I said, you have to follow the chain of command. If you are the supervisor, talk to the administrator. If the administrator is not around, call them. Don't jump protocol. So if a med aid exceeds those tasks, the specific job duties outlined in this course, and the ones that the policy and the procedures inside your facility, it may result in legal and disciplinary action by the facility, number one, and by the state regulatory agency. Now remember, all these facilities that you're going to be working, the states come there sometimes unannounced. The med aid may lose eligibility to work in certain healthcare areas. Now, I know that if they put you in the abuse registry, you cannot work in the healthcare. It's not some areas. You cannot work. So we have to be very careful. The adult care home will have a thorough understanding and specific policy and procedure regarding your role as a med aid that you must follow. Responsibilities of the med aid varies in adult care homes, like I've already said. As a med aid, you can expect validation of your skills by employing facility, orientation to facility policy and procedure regarding medication management and medication administration. So what are the roles of the other healthcare providers that you are going to be seeing along your work line. So a healthcare provider, such as the physician or the nurse practitioner, will diagnose the disease and decide on treatment, which may include prescribing medication according to the needs of the resident. The registered nurse, that's who I am as a registered nurse, we are involved with assessment, development, and the care coordination. So RNs do the plan of care. Registered nurses are licensed to administer medication by all routes. LPNs, which are the licensed practical nurse, they are limited to some things, but an RN can do all routes. Pharmacists will they dispense and they bring in to the building the medication that has been prescribed by the nurse practitioner or the doctor for the resident. So any sorts of question with medicine, such as missing medications, dosing precautions, it goes to the pharmacist. You call the pharmaceutical company and get it from them. Med Aide should know whom to contact. So if a resident needs an assessment or evaluation prior to administering a medication, you need to know who to talk to. If any questions or concern related to medication administration, you need to know who to talk to. If a resident refuses medication or the medication is not available for you to administer it, know who to talk to. So always know your chain of command. Always know your chain of command. All right. Any questions before we go to section C? Does anybody have any question for me?
No, ma'am, no questions.
All right. So we're going to look at legal and ethical responsibilities for our med aides. Legal and ethical. So with this, we have the handout that goes with the legal and ethical responsibilities. And so we're going to look at medication errors, good medication administration practice habits, and then resident refusal to take medications. Med aides may face with making decisions about consequences of an action or behavior. Some decisions involve the moral right or wrong of an action. Others involve legality of the action. At times, decisions may have both ethical and legal implications. So as a med aide, you should have the knowledge to make sound decisions about a particular action or behavior. It is very, very important. So what is ethical? What is legal? Let's look at the difference there. So ethical standards are guides to moral behavior. An example would be every person deserves respect and every person has his own beliefs. That is the ethical aspect. So you are an American, your resident may be Mexican, your resident may be from Africa, your resident may be Asian or from European descent. Whatever you believe in as an American may be different from what they believe in as Asian or as African. It is very important that you get to understand these things. So don't force your belief or religion or whatever it is that you think should be on your patients. No. I work as a travel nurse in one facility where there's an African person, and the history they were giving me is that somebody brought her there and nobody ever came to see her. She's speaking in a dialect they don't understand, and nobody there understand what she's saying. And every day she's repeating the same thing. And I know she was trying, I wish she was speaking my country language so I could interpret it for them. But what she was speaking sounded like a country that shares border with me, Togo. The language sounded like Ewe. And I'm not from that tribe, so I do not understand. But I've heard them speak before, so I could hear that was some of the things, but I completely don't understand. And it breaks my heart that there was nobody there to understand what this lady is crying out for. You know, and this can breach ethical standards in that facility because nobody's able to communicate with her to know her needs, to know what she's screaming and talking. She doesn't understand English. And I'm like, wow. That night that I worked there, I was really, really brokenhearted just looking at that woman. You need to know legal standards are guides to legal behavior. So, an example is performing your job according to the facility policies and state regulation. That's the legal standard. Because if you go outside of your job role, there's legalities that are involved. So negligence, let's look at that. This we are looking at the legal implications. What is negligence? When a person does not provide the standard of care that a person is trained, another person who is trained in the same way would do in a certain situation, it will be considered as negligence. So, example, failing to give medication that have been ordered and transcribed on the MAR. So, if you mark that you gave the blood pressure pill, meanwhile you didn't give it, that's negligence. And if by so doing that patient didn't get their blood pressure medicine on time, and so it spiked to the point of them getting seizures and everything, your license can be taken away from you because a prudent nurse, a prudent med aid, in the same capacity would have given that medication. So why didn't you give it? So people will be crying aloof. Oh, they threw me under the bus, blah, blah, blah. But did you cross your T and dot your I's? If you have done everything, your due diligence and everything, then there will be enough proof that will vindicate you in any law case. I've seen nurses, who have been accused of negligence and the patient dying. And at the end of a long legal battle, proofs within documentations and objective documentation, which will be vital signs and everything, vindicated them. And hospitals have to pay millions of dollars to these nurses. So it's very important. It's very, very important. Remember, we as citizens of US have certain rights. Additionally, there are resident rights, which include being free from neglect. Fraud. These are one of the legal implications. When a person is dishonest or cheats the system, like what I just said, you're writing, you gave it, but you didn't give it. That's dishonest. Misrepresentation of any aspect of the job. Possible disciplinary action by the facility and may involve legal charges. If a medication is documented as having been administered but was not, that's what I just said. That's fraud. CNAs are losing licenses, med-aids are losing their licenses, RNs, LPNs. Lately the law is after licensed personnel that are not doing the right thing. Okay, especially in the nursing homes. Diversion. Now we have addicted caregivers who are addicted to drugs. They pull the medicine, document as given, and they will take the medicine. They will not give it to the resident. That's diversion. They pull the medicine and go give it to another patient. That's diversion. Don't do that. That's stealing. Robbing Peter to pay Paul. This resident is paying thousands of dollars for that morphine. They are in pain. And then you take it, you go give it to another person. That's wrong. Knowingly giving a medication to someone other than the resident the medication was prescribed for, but documenting the medication was given to the resident. Stealing medications. Never give medication to people whom the medications are not intended for. even when it seems harmless. Don't do it. Do not do it. All right. So, what can subject you to disciplinary action and may involve charges? Example, if the med takes medication intended for a resident and uses it for other reason. Giving a resident pain medication to a co-worker who has shoulder pain. This example cracks me up. People do that all the time. Yes, people do that all the time. You might think someone will not do. So I'm going to also email you the handout as well, so you can be reading through it. I'm going to give the handout as well, so you can be reading. So before we look at the handout, so let's look at what med errors is. When a medication is administered in a way other than how it was prescribed, administering medication that is not prescribed for a resident is also medication error. So something that is oral and you gave it through the anal or rectal, that's med error. You weren't supposed to give that medicine and you gave it, that's medication error. When the med does not transcribe a physician's order correctly, does not compare the instructions on the medication record book and the directions on the bottle, or the approved ways to administer medication, an error may occur. Medication errors often have serious outcome. Administering medication carries a great responsibility, including the need of being extremely careful and following it methodically. You need to follow it step by step. That's what it means. Mistakes in giving medications are one of the most common causes of harm to our residents under our care. Giving medication to the wrong resident can be a dangerous error. Now, let me tell you one incident. I work as a travel nurse. I went to a facility to work one time, and two residents are in the room. They carry the same last names. One was the mother, one was the daughter. I didn't know. When I pulled the medicines, when I got to the room, the daughter looked at me and said, "You are new in this facility?" I said, "Yes." And he said, "That's my mother over there, and I'm her daughter. We are both in the same room, and we have the same last name. So go and check your medicine and make sure what you are about to give to my mother is not what belongs to me." I went back to my medication card, and I'm looking at the name, and I'm like, what? They bear the same last name. Yeah. And I'm like, why in God's name would this facility put these two women in the same room, for crying out loud? This is tantamount to med error. And I'm like, I wonder how many nurses have caused med error with these two people. I had to go double check what I pulled, because I could have given it to the daughter. The names are the same in front of the door. And nursing homes are very notorious for, you look at the the MAR, they have a picture that is 15 years old picture, meaning that the resident has been there more than 10 years or more than 15 years. They took it when they were admitted. They don't take current pictures, images of the residents. So an image will be there. So if it's telling you, oh, check the face, check the picture in the MAR, wrong. That picture may be 10 years old, and that woman may have they may be looking different. After 10 years, they don't look the same. So they stop us from using that. They said, don't do that, because the woman in the bed is different from the woman inside that, in that picture in the MAR. Mistakes in giving medication are What, like I said, is one of the most common causes. And it's very dangerous when you give the medicine to the wrong person. Potentially serious types of errors that can occur and cause harm to the resident. It includes giving medication to the wrong resident, giving medicine at the incorrect time, omitting a dose, giving the wrong dosage, giving an extra dosage, giving a medication by the wrong route, like I said, something that goes in the mouth, you put it in the anal area, giving the wrong medication, and giving an expired medication. These are all errors. These are all errors. We have to be. Remember, if you are in doubt, don't give it. So as a med aid, you are to report errors immediately. If you are the supervisor there, immediately talk to the administrator. What has happened? Now, you'll be tempted to say, okay, nobody saw me, so let me quickly fix it myself and move on. Don't do that. Why you shouldn't do that? Because why you shouldn't do that is because somebody else, another med aid, could make the same error. If you don't report it for it to be fixed, the error could continue going. And eventually that resident will die. That resident could die. So do we want to kill them or keep them alive so we can keep making money and working and keeping our jobs? We want them alive, right? Yes. We want our resident alive. We don't want to kill them. And an error can kill them. An error can kill them. So you want to protect your licenses. I understand that. You think when you report it, you lose your license. I understand that. But think about the life of that person. Think about the errors that could continue. Think about if they don't catch it on time and the state people come in and they come and find that out and shutting the whole building down. Of what good is that? So that's why it talks about ethical, what is morally right to do. Medication aid is to document medication errors after notifying the supervisor of the error. Always document so that it will serve the right purpose, so it will not be repeated. So ways to prevent medication errors. How do we avoid these med errors? Always use the 6 right. That's the number 1. Right person, right route, the time, the dose, the documentation, the 6 right. Use it. If you cannot read or understand any part of instructions on your MAR or what needs to be done to give a medication, ask before giving it. Ask the person above you before giving it. Wait to give any medication that has raised any concerns or questions until talking with the supervisor or the administrator or the doctor or the registered nurse. It is better to be safe than sorry. Sorry will not bring anybody to life. Sorry will not bring anybody to her life. And as part of the moral compass, when you fight with your husband or your partner or whoever it is at home, your children, don't bring your frustration to the workplace to give medicines. Because out of frustration and whatever it is that is messing with you, if you have to call out, call out. But by all means, don't come to work frustrated, stress, if you're facing any abuse of any sort, you will not be in the right frame of mind to do your 6 rights check, be checking, I know these people, and then you'll be pouring out of the frustration in your mind. You are pouring, giving. You can cause error. So I always tell my co-workers, whatever happens at my home stays in my home. By the time I'm entering the hospital building door, I leave everything that happened at home in my car. It doesn't come along with me to the unit because those co-workers and my patients deserve better. They didn't cause me any frustration. They didn't cause me any pain. And I'm there to work and get paid. So I have to do my job right. They deserve that. I've seen many co-workers, nurses, and even supervisors that clearly you can see that they are frustrated. They are frustrated human beings from their house, and they brought that frustration into the building. Don't do that. You can cause errors. Don't do it. Seek help if you have to. Passing medications is a serious business. You are the last checkpoint. Someone's life depends on it. Remember that once medicine is swallowed or administered, it is too late to get it back. That's right. If you are in doubt, don't give it. If you are what? In doubt, do not do what? Do not give it. Okay, so before we look at the handout part, borrowing medications, let's look at that. Do not borrow medication from unit stock or another resident medication supply unless an emergency and your supervisor and the MD, the medical doctor has been notified and directed for you to borrow. Unless it's been approved, don't do it. For a new medication, it would bypass the checks and balances needed, such as having the pharmacist check a new medication against what the resident is already taking to see if the new medicine reacts with the medication the resident is already taking. So if the medication is in the right dosage form, or if there are allergies, these checks are done prior to the ordered medication being placed in the resident medication supply. So these are things that the pharmacist will take care of. Your effort to speed up the process by borrowing a medication from another resident may indeed be costly. Don't do it. Additionally, the resident you borrow from may not have the medication they need at the time they need them. So you are short-handing somebody when they will be in need of it. Now you've taken it from them and you give it to another person without talking to any other person. So what should that other resident do when they need it? What should they do? You've taken their medicine from them. They paid thousands of dollars for. It's not right. So we're going to look at the resident refusal to take medications. That is in the handout. We're going to look at that. Independence and refusal. So encourage all residents to be as independent and participate in their medication and treatment, as much as they can. So when you bring in the pill, it's in the cup, the medicine cup. If they are led and oriented, don't take it to their face and say, here, take it. Put it on their table. Say, I brought your medicines. You don't leave the room, but you can stay there. Say, I brought your medication. You set it in front of them. You bring 8 ounces of water in their cup, or they might have the water jar on their table already. So let them independently take that cup and take their medicines. Give them that autonomy. So occasionally a resident will not or cannot take a medicine. If a medicine is not administered as ordered, whether refused or not given, report it to your supervisor or the administrator and follow the facility's policy. If a resident chooses to refuse medication, Med-Aid documents the med was not taken. There will be a place to document the missed dose, either on the back of the MAR or another designated place. Your facility will show you where to document. It is important the Med-Aid documents why the medicine was not administered. Some Med-Aid will be administering medication to residents who are mentally impaired. So that's what I was talking about, alert and orientation. If a resident is mentally impaired, they may not understand the benefit of their medication and they may refuse them. If a resident is not capable of making informed decisions about their medication and they refuse to take medication, seek advice from the administrator if you are the supervisor, or if there's a supervisor, seek advice from that person about strategies for encouraging the resident to take that medicine. Never do anything that would be considered forcing a resident to take their medicine, even if they are impaired. Okay, even if they are stage 5, stage or the last final stage of Alzheimer's and dementia. Even at that, don't force them. For residents who are not able to give consent for medication, such as incompetent resident, the legal guardian will provide consent. For residents with cognitive impairment, it is important to involve the family or the resident designee when the resident refuses medication. Okay, so respect, that's part of the resident right. How the resident is addressed. Do not interrupt a resident while eating for the administration of medication, such as oral inhalers or eye drops. And med aides and nurses do that all the time. The person will be sitting in the dining table eating. They will take their medicine there to go and put eye drop. Don't do that. Come on. Let the person finish their medicine. If you could catch them before they start their medicine, and sometimes some of the medicine, I mean, they have to eat it with food or they have to eat it before they take the medicine. So an eye drop can wait. An eye drop can wait. Don't go and interrupt them when they are eating. If you don't want anybody to do that to you, why are you doing it to another person? Always have that in mind. If I wouldn't want that done to me, I don't want to do that to my patient. I don't want to do that to that client or that resident. Don't go to the dining table and go and put an ointment. They can't see right to eat their food when you do that. Why interrupt their meal? You know? So don't do it. Don't go and push any inhaler in their nose. Don't go and give them the one that goes in their mouth as well. Don't do it. Let them finish eating. It may be taking long, yes. If you could catch them before they start eating, fine. If not, don't interrupt their meal. Okay. Answer a resident question about the medicine and refer it to the supervisor or the nurse when you do not know. Okay. Some basic thing like, oh, I used to take that Centro, it was blue. Why is it gray? If you know that pharmacy has changed, and so it could be the new pharmacy bringing it in a different form, but you can tell the resident that if they insist, go get the administrator to come and do the explanation. Go and, if you know that is the actual truth, you can tell them, hey, so the facility changed pharmacy from Omnicare to CVS, and this is what is the same medicine, but see, and there's no. Let me talk to somebody else. Go bring the administrator. Go get the doctor on the phone for them. That's the right thing to do. So resident has the right to refuse medication. Never force a resident to take a medication. Follow the facility's policy and procedure when a resident refuses medications. Policy and procedure ensures that the primary physician or prescribing practitioner is notified in a timely manner based on resident's physical and mental condition and the medication. Privacy. Being away from the public. Knock on closed doors before entering. Knock, knock. Hey, Miss Joey, this Grace. I'm your med aide. I have your morning medications here for you. Don't just be barging in their rooms. Do not administer medications when resident is receiving personal care or bathing or in the bathroom. And I've seen medics do that. I've seen nurses do that. The person is sitting on the toilet. They are bringing their medicine to shove it in their throat. Don't do that. Allow them some privacy. Administer injections in a private area. Don't go and give them their insulin when they are sitting at the dining table chatting with the other resident. Don't do that. Let them go to their room. You want everybody in their business. Don't do that. Give them honor, respect their privacy. Okay. Because it might involve you have to pull their dress and give the insulin in their belly. And you're going to do that right in front of other residents. That's not right. If it's a rectal or vaginal administration, they definitely have to be in their bed with doors closed. All right. Chemical restraints means a drug that is used for discipline or inconvenience and not used to treat a medical symptom. Do not administer medication for staff convenience. Maybe the resident has Alzheimer's. They are shouting and screaming, and their shouting is irritating you. Oh, they have a PRN advent. Oh, let me go and give the PRN advent because the resident is irritating you. You are going to give them advent. Don't do that. That's called chemical restraint. They have the right to scream and shout. Sometimes they screaming and shout. It means something else may be wrong with them. But you are getting irritated. You want to shut them down. You know, giving them advent will make them sleep. So you shut them down. How about going close to de-escalate the issue? As the caregiver that you are, approach the person. Hey, Miss Joey, what's wrong? What's going on? Are you in pain? Sometimes they may be in pain. They cannot express it to you. That's why they are shouting. Don't shut them down and give them advent. Nurses do that all the time. Med aides who have been in the system, they also do that. Oh, go and give the person, so it will be quiet for the rest of the night. But the person might be suffering. There might be something else wrong. So always remember that. All right, so looking at the handout, this is the handout C. So medication errors. So when a medication is administered in other than how it was prescribed, it becomes an error. Okay, so omissions, that's what we talk about. When you crush a medicine that you are not supposed to crush, you cause an error. Documentation errors as well. So what's your role as a med aid? So you need to understand the facility's medication error policy and procedure, or know where to locate it. Recognize when a medication error is made. Understand the importance of acting quickly to report and correct medication errors to help prevent more serious problems. The quicker the error is noted and reported, the better for the resident. Always remember that. Reporting all details around the error can help facility identify issues that may have contributed to the error. And the facility may be able to make changes based on the information provided that can help decrease medication error in the future. That is why we have to report. So don't hide it. Okay. Always read the medication labels and compare the label to the medication administration book. Perform your 6 right every time you are giving medication. You are tempted to skip it, but please don't do that. Read it in your head. Do not skip these important checks. Okay? Do not skip it. Be sure to question unusual orders. For example, if more than 3 tablets or capsules are needed for 1 dose of medication, there is a good chance that you are preparing to give too much medicine. A red flag should be raised in your mind if the resident says they do not normally take this medication. They tell you, why are you giving me this blue pill? I've never taken any blue pill. Don't give that medication. Go and double check. The right resident, the right medication, the right dose, the right route, and the right time. Very important. It is possible you have the correct medication and the pharmacy supply has changed, just like I said previously. So when when pharmaceuticals are changed for facilities, they can change the shape and the color of a pill. It might be the same dose, it might be the same, medicine, but looking different. But it is very, very crucial that you do that double checking and making sure you get the right information. So that resident will be at peace that, oh, I'm not taking a new pill. It's the same one, but it's coming from a different company. You need to recheck your MAR prior to giving the medication. If you continue to have doubt, make sure your administrator is aware if you are the supervisor. So again, with refusal, the resident always has the right to refuse medications. Residents refuse to take medications for many reasons. And some of the reasons could be the effect or the side effects are unpleasant, are unwanted. The medication tastes bad. I've had residents that when you are bringing them a pill, they're like, yike, that stick taste. They have a liquid medication. I've forgotten the name of it. It makes them move their bowels. God, it's kind of thick and green. Even me look when I look at the even just looking at the appearance of that medicine, I'll be like, this is going to taste very yucky. This is going to taste very nasty. So when they make any sound, I'm like, I know it doesn't taste. Here, drink some orange juice with it. I try to take something that can, ease. So a resident has they might be refusing that medicine for something. If you are dealing with an African person, an Asian person, religious, ethnic, some kind of belief they may have, you know, they may not want to take it. So you need to be able to explain something to them. Some people they may have some delusional beliefs that you are there to poison them, you are there to harm them. When those people that have psych issues, they know that whatever you have is so they know that whatever you have is going to do it. You are there to kill them, you are there to harm them. They may have some grandiose stuff, in their heads. So always try to understand why they are refusing. So we have types of refusal. The actual refusal is when a person directly refuses to take the medication. And then we have the passive refusal. It's less direct and requires closer observation. Which one is that? Is that the resident takes medication but later spits the medication out. So he or she may not attempt to hide the medication. So I've had residents that pocket medicine underneath, either in the buccal area or inside, under the tongue. They pretend they have taken it, but they don't take it. We used to have a resident like that in the nursing home that I went. And so we got to find out she was packing and then she was spit it in the trash can. So then a new policy was made for her, a new care plan. So nurses, we are supposed to stand there, make her take it, watch her take it. And then we will have to ask, open your mouth. Let me see under your tongue. They have to do, they have to do something like that for us to know that she has taken it. Before, it was inside her plan of care or the care plan. Does the resident experience any unpleasant effect from the medication? Does the resident have difficulty swallowing? Is the resident afraid for some reason? Is the resident refusing other medical treatment? So you need to find out, as a medic, you need to find out all this. And then you need to bring it to the attention of the supervisor or, whoever their resident care person is, so that the care plan can be changed around, and the problem, find solution to it. So examples of strategies for dealing with resident refusal. If the resident refuses and gives no reason, wait a few minutes and then offer medication again. If the resident refuses again, try again in another few minutes before considering a final refusal. This is particularly important with residents who have diagnosis of dementia. So, like I said, the policies in the care plan and everything might be different. So just follow that. For residents with cognitive impairment, such as dementia, it is important to know when the resident designee or whoever is the responsible party want to be notified if the resident refuses. And they may be able to come over and talk to them and encourage them. So notify the practitioner or your supervisor when they refuse the medicine. Document the refusal. Observe the resident and report any effect which may result from the refusal. If there is a swallowing difficulty, report to the administrator, if you are the supervisor, and the doctor, follow the chain of command and report. Consider changing the time of administration. If they don't want it too early, they can change the times around and give it maybe late morning. She may like it that way. Okay. If the consider changing the time of administration if taking the drug interferes with an activity or with a sleep. So some medication, a medication like Lasix, is a diuretic. It may limit a resident's ability to participate in an outing because of the need to go to the bathroom frequently. So if that day is an outing day, they're going to go to the park or go for sightseeing, and she has to take that medicine. The time can be changed around. That when she comes back is when she's going to take that medication. You talk to the MD or the nurse practitioner. If there's a suspicion of passive refusal, such as they putting it under their cheek and not taking it, that's called cheeking, or vomiting after, follow the recommendation for actions in the individualized care plan. Okay, it's very important. And if the refusal continue, explore other options with the resident's medical practitioner. So passive refusal is not uncommon in residents with diagnosis of mental illness. It is important the resident, whoever is the designee or the facility nurse, staff, pharmacist, we have to work together to develop or follow a plan to assist the resident to adhere, because their refusing is not helping them in any way. All right, we're going to take a quick 10-15 minutes break. And then when we come back, we'll go to the section D. So I'm going to pause the. So welcome back. All right, I'm going to share my screen. All right. And we're going to go to. So when you get the handout in your email, just go through them from one. They correlate with your manual. It tells you, refer to the handout, section D or section C, but most of it is the same information. All right. How do I push this? There we go. What's in my way? Okay. So section D. So overview of medication administration. So we're going into the nitty-gritty details of so at the end of section D, you should be able to be proficient and know safety in preparation of medication, and then also be aware of the commonly used abbreviations and terminologies in the medication world. Be able to read medication label, identify the 6 rights to administer your. So we're going to look at the section D part as well, the handout, the section D part, this session. So you understand it more when we meet on the 3rd day, for you to see how all these things play out. And tomorrow when you watch the video, you see how they demonstrated. So preparing to administer medication. So one of the common words, either someone is saying medication or saying drug. They use this interchangeably. Medications are more commonly used when talking about drugs used for therapeutic or helpful effects. So in this course, the word medication will be used when talking about drugs or medication that are prescribed for the resident that you're going to be taking care of. Administering medication is an important responsibility and must be taken with great care. It's never an easy task, and thus cannot be undertaken when you are trying to do several things at the same time. So I've seen med aides, I've seen nurses, They'll be on their phone charting, or someone else will be talking to them while they are trying to pull the resident medications, either from the bottle or from the drug card that has the medicines inside of it. Don't do that. It's a no-no. The likelihood of making errors when you are multitasking, when you are doing medication administration, is very high. It is very, very high. In order to prevent med errors and possible harm to your resident, you must focus on doing your medication administration solely. Do not talk to others whilst you or they are preparing and giving medication. So if it's two people working in the same facility, the same building, whilst the other person is doing medication administration, the other aide cannot be chit-chatting with them. Please leave them alone. Let them do the right thing so that they don't cause med errors. Because somebody, oh, we are women. We are used to multitasking. Not in the case of medication administration. Don't do it. If you are in your own house and you can be cooking and be on the phone, cooking is not the same as passing medication. So we cannot bring our multitasking, quote unquote, skills as women into our job place where we are med aides. Don't do it. Do not stop this task unless there's an emergency. So whilst passing medication, and then you hear code blue, code red, there's a fire. Unless that emergency situation is when you should stop what you are doing. Stopping and starting can cause medication error. So that's why we're trying to avoid that from happening. Give medication to one resident at a time. I've seen LPNs, I've seen RNs, I've seen medics. What they do is that, okay, there are two patients in one room. When you go to the skilled nursing homes and the assisted living, a room can contain two people, two beds. Okay, so they try to pull bed A and bed B at the same time. Don't do that. Even though it looks very convenient, okay, you have 22 patients to pass medication to. You have 15 patients to pass medication to. So you think pulling, two at a time because they're in the same room is convenient. That convenience can cause murder, that can kill somebody or put them in a very, great danger. Don't do it, please. This will help prevent getting one resident medication mixed up with another resident's medication. Before taking the medication to the resident's room, mark your place in the MAR. It didn't say sign for it. Know where you are. You can put your pencil or your pen there. Okay, so you know what you have pulled so far that you're going to give. Because one resident can have tons of medicines. I, at some point, had some patients that I had to have 2 medication caps. When you come to the skills lab, you see the medication caps. We have the paper caps and then we have the plastic caps. I used to have, when I was working in the assisted living in Tennessee, I used to have one lady in the morning medicine that we give, 2 medicine cups, it's full of medicine for her. She was from blood pressure pill to blood glucose pill to every other thing you can name under the earth. She's on every medicine. So such a person, and you are pulling her medicine and you are pulling the other person in the B bed. Don't do it. Remember to pour 8 ounces of water in a cup for the resident to drink with their medication. When all medications have been swallowed, encourage the resident to drink another cup of water to make sure all the medications were swallowed and it moved into the stomach. Encouraging the resident to drink water also helps them to stay hydrated. Now, our elderly populations, they are at higher risk of dehydration, especially in the adult care settings. When you have a lot of residents to deal with, it's very, very common that these people are, when it comes to hydration, they are very, very neglected. So most people end up very, very confused because of dehydration. When a resident is highly dehydrated, they can get into confusion state. And you might think, oh, it is a dementia. That is no. She is confused because she's dehydrated. Many people don't take that into account. It's very important that we hydrate our residents at all times. So as a PCA and a med aid, you are learning that hydration is very important to the elderly population. Oftentimes, residents do not drink enough water. So encouraging drinking of water at the time of medication administration will assist them in getting the amount of water they need each day. Giving the resident a sip of water before you give out the medicine to swallow, it makes it easier for them to swallow that pill. Some of these medicines are like a darn horse tail. Okay. Sometimes some of their medications, like it's a sugar medication. Forgetting the name of it. It's to regulate their blood sugar. It's a very big old pill. Sometimes these pharmacists, I don't know what makes them, make the drug in that big form. So some of them have big old long capsules, big old tablets, and it's hard to swallow. You may have to break it into two. And that's why there's the need to wash your hands, do your hand hygiene first before you start passing medications. And you have to put on gloves. If you have to touch any pill to break them into two for them to swallow, you can't break a capsule, but the tablet form, if it's too big, you know that this tiny lady cannot swallow this thing. Break it into two. Sometimes I use the pill cutter, and you see it in our lab. You see the pill cutter. I use it to cut the big old ones. I'll cut it into 4 sizes. I'm not crushing the medicine. I'm just bringing it into smaller. You have to use your judgment. For me, I use my nursing judgment. So I want to make this easy for swallowing for my patient. So I cut them, the bigger tablets, I cut them into small. I use the pill cutter, cut it into 4 equal sizes, and then I hand it over. So they'll be able to. And sometimes the residents who are with it times 4, they are led and oriented. They will tell you, can you cut this big old pill? It's hard for me to swallow. So you can't be huffing and puffing because you think she's wasting your time. Imagine yourself in that same condition. Is that how you want to be treated? Huffing and puffing because they are asking you to break their pill. So give them water to drink first for easy swallowing. And sometimes you can break it down for them if they need be. Don't crush it if you don't have to crush it. If it's not a crushable pill, don't do it. Some residents take multiple pills at a time, at one time. Ask them how they like to take their pills, one at a time or several at a time. If they prefer only a few at a time, assist them to take 1 to 2 pills at a time. It may be helpful to give medication to residents who do not need assistance first, leaving those needing assistance last. This is a helpful tip that you have to remember. If you are taking care of 6 residents in the facility, which is the family care home setting, okay, you have 2 of them that are slow in swallowing. Go and do the rest. The others who can take theirs faster, let them finish. Then you come to the slow motion ones. Take your time with them and help them take their pills. If they can take 2 at a time, give them the little ones 2 at a time. And then there's the bigger ones. Like I said, if you can break it into, use the pill cutter to break it into smaller bits, do that for them. Let them swallow at a time, small at a time. Before you begin administering your medication, check for any specific information needed prior to giving certain medications. Example is heart rate or pulse, blood pressure, blood sugar readings. So as a med aid working in the adult care setting, one of the skills you are learning is how to do your glucose monitoring. if they are diabetic. The med aid in the skilled nursing home, they don't do that. But you, the med aid in the adult care setting, you do that. So know the sugar level. If the blood sugar level is 100, when you look at the MAR, it will tell you that if the range is 100 to 150, no insulin. So it means you hold the insulin. So you mark it as held, and then you give blood sugar is equal to 100 in the MAR. You mark it. There is a pill, a blood pressure pill. If it says that hold the medicine, if blood pressure is below 110, don't give it. And you took their blood pressure, it was 109. You hold that medicine and put in the MAR, held, and then you put underneath where you are supposed to document blood BP. You put your column and then you put the BP there, so that anytime the state comes around, the doctor comes around and check, they'll know that, oh, it has been held multiple times because their blood pressure was within this range. This gives the doctors an idea that, okay, we need to reduce their the dosage that we are giving to this person, because for about a month now it has been held. It means whatever dosage they've been taking is too much for them. If you are not doing proper documentation, how would the doctors know how to adjust the medications of the residents? This is why you are taking this course. It's very important. This is why you need to know how to do your vital signs. This is why you need to know how to do your correct sugar checking and reading. Because if it doesn't read right and it reads high or low, it's going to affect the person. There is a drug called digoxin. You have to check the person's pulse. If it's below 60, you have to hold it. You have to know all these things. You have to read them more to know what the parameters are for that drug, that medication before you give it. Another factor to consider when administering oral medication is how the resident is presently feeling. If the resident is vomiting or has a change in behavior, contact your supervisor or the administrator or the physician before administering the medicine. Residents may have serious side effects after taking certain medications. Side effects include change in behavior, change in alertness, change in eating or swallowing, change in mobility, skin rashes. So let me give you a typical example. Last year by this time, I was preparing to take 2 major surgeries in Atrium Hospital here in Concord. After the surgery, because of the severity of what was done, the doctor couldn't discharge me. But the original plan was to discharge me. I go home that same day. But due to the severity of what they had to do inside my abdomen, I had to be in there for 2 days. Now I was in severe pain. The doctor has prescribed oxycodone. As soon as they gave me the oxycodone, I break down in rashes. I never knew I had allergies to oxycodone until that day. I broke down in rashes. I was itching, screaming. The nurse came in and said, look at me. You just gave me oxycodone. And they had to call the doctor immediately. And they had to give me a pill to stop they had to give me diphenhydramine to stop the itchiness that I'm feeling. And they changed the oxycodone to hydromorphone. So these are some of the side effects of the medications our patients or the resident can be taking. Okay, so you need to observe the changes. When they take the blood pressure medicine and they cannot, after 30 minutes, they can no longer get up and walk with their walker like they used to. You have to let the physician know. It might be that the dosage is too high. They need to reduce it. So these are things that as a med aid, you need to observe, you need to be reporting. If you are not doing that, you are not being a good med aid. Yeah, it's causing more harm to the resident than helping. When there is a change in resident, follow the facilities policy, what to do, who to notify. which may include notifying your administrator if you are the supervisor in charge, healthcare professional, or the physician. Not administering a medication without first having contact with the resident physician. You have to know all these things. How to not give that medicine because you have to contact the MD. Observation of resident is an important step, like I just said, in the cycle of medication administration. Resident physician and healthcare providers often depend on the observations of direct care staff when evaluating residents. So in the hospital where I work, the morning doctors, they do their rounding early morning when they come around 6 a.m. They come and look for the nurses for the patients. Hey, Miss Roslyn, were you the patient for patient room B? Yes, sir. How was he? How did he do with his medicines? They want my observation. They want to know what I observed with the patient. Was he drowsy? Was he throwing up? Was he throwing a fit? So? Example: if someone came in with alcohol abuse, alcohol intoxication, we have to observe him throughout the night. We are doing what we call SIWA. Every 4 hours we are going in. Is he hallucinating? Is he sweating? Is he able to give me, if I count 1, 2, 3, is he able to do that? In the morning when they come for the rounding, they depend on me as the direct caregiver to give all this observation so they know how to adjust their medicine. Do they need more Ativan? Do they need to reduce the Ativan? Do they need to get morphine? Do they need to get... That's how it goes. So as a med aid coming in, remember, you are the eye and the ears of your doctor for these residents. It's very important that you are very observant what you see and report it. To ensure safe care, the med aid must know how to observe and report changes in the residents and the resident mental status, the physical and their mental status. Med aid must know what to report, to whom it should be reported, and when and how to report observations. These are all things that the facilities, will show you how to report these things that you should know. Medication allergy. I just gave you an example of myself, how I started reacting to oxycodone immediately when I didn't even know I was allergic to. So now it's on my medical records with Atrium. And any hospital that I go, they will transfer it to them and let them know, don't give this patient oxycodone. And it is there what happened to me when I took that medication. So a reaction occurring as the result of unusual sensitivity to a medication or other substance, that is what we call medication allergy. It may be mild, it may be life-threatening situation. Mine was moderate. I would say moderate because that rashes came on me immediately. It could have been something else. It could have worsened if they didn't give me the allergy pill to stop it from reacting, because I was beginning to itch seriously. Not just the rashes coming on me, I was beginning to itch terribly. I was scratching my whole body. So they have to give me something to counteract that effect. So life-threatening is when the person is even dying out of that reaction. They can go into what we call anaphylactic shock. Their throat will be clumping together, eyes bulging out, swelling, and everything in between that. That's life-threatening. So it may include rashes, like I said, it happened to me, swelling, itching, significant discomfort. That's what I was feeling. Very great discomfort, not just, it was undesirable. I was like, help, somebody help. I was itching terribly. So you have to report it to the physician immediately. So your role as a med aid, you should understand that information on allergies should be reported to the pharmacy and the physician. And this information is recorded in the residence record. Upon admission, important to document any known allergies. If there are no known allergies, should be documented. It should also be. So you should know the care plan. As a med aid, read your resident care plan before you start giving medication. You need to know what they are allergic to. Sometimes there can be an omission and oversight on the part of the pharmacist. So you are the last checkpoint. Again, remember this word. You are the last checkpoint. If there's a medication that is on their care plan that they are allergic to and is inside their medication card, you should let the pharmacy know. Provide immediate emergency care if severe rash or life-threatening breathing difficulties occur. So all this should be in the MAR, all those information. Medication orders. What is a medication order? The written or oral direction that a physician or other prescribing practitioner provide about the resident medications. That is a medication order. So on the phone, the doctor calls and say that, okay, Miss Joey, I'm giving you an order. And then the doctor will say, Tylenol, 325 milligram, two pills, two of the pills. So the strength and how many you are giving, the dosage. The person is supposed to take it by mouth. It's a tablet. He's going to take it by mouth every 4 hours. And then it will tell you if they say that their pain is between, on a scale of 0 to 10, if they tell you their pain rate is 4 to 6, give them 2 of the pills every 4 hours. If you check their temperature and their temperature is 101.2, give them 2 of this Tylenol and check every 6 hours and can be repeated every 6 hours. This is how a medication order looks like. So there has to be a reason they are giving it and a specific direction, frequency, how many times it can be given, which route, which part is taken. Is it an eye drop? Is it a nasal spray? Is it an oral medicine? Is it something that goes in the ears? Is it a rectal? Is it topical on their skin? It has to be specified. How much is the strength? 325 milligram. And what's the name of the medicine? These are the components of an order. You have to know. All these that we are learning, you meet some of them in the state exams. So don't say you didn't know. Okay. So medication name, the strength of the medication, dosage of medication to be administered, the route of medication, the route where you are supposed to give it, specific directions for use, including the frequency. So every 4 hours, every 6 hours, that's the frequency of it. Reason for administration. So are we giving it because their pain is between a 5 to 6? Are we giving it because the fever is 102.9? That is the reason you are giving it. All right. Orders for psychotropic medication prescribed for PRNs. It must also include symptoms that require the administration, exact dosage, exact time frame between dosages, maximum dosage to be administered in the 24-hour period. So we're going to look at the handout for the medication orders. All right. All right. So what you will not do is to guess something. What you will not do. If the orders given is not making sense, it doesn't follow this order that we just talked about. Don't guess it that, oh, maybe, don't assume for the doctor. Call them back for clarification. Let them clarify. If an order is not complete or clear on how to administer, the med aid must contact the physician or the administrator if you are the supervisor. Don't guess anything. If the order is not legible, you can't read the order paper well. Do not guess it. Don't assume anything for them. Okay. So we're going to look at the different types in the handout. An order is required to administer, to change or discontinue any medication or treatment So if you are doing any treatment on the patient, like they have any skin tear, you have to put some cream on and everything. If the patient don't want it again, just let the doctor know. There has to be a discontinuing order in uh, uh, their record before you can stop giving a medication or a treatment. Before you change a dose or anything, there has to be an order. So contact the prescribing provider if the order is not legible. Again, don't guess it. If it's not complete, how to administer, don't guess it. You have to ask. Okay, the types of medication orders. There are 4 types of medication orders. We have the routine orders, we have PRN orders, we have one-time orders, and we have start orders. We're going to look at each one step by step. It should be clear on your MAR what type of order the med aid is being asked to follow. The most common orders in adult care home are the routine orders and the PRN orders. When you hear start, most time it's in the hospitals that you hear start. And one time orders, sometimes you can see that in the adult care homes. But mostly it's going to be your routines and your PRNs that you're going to see. So medication, the med aid is allowed to accept verbal order. Again, med aid is allowed to accept verbal orders or orders over the telephone, but obtaining a written order from the prescribing is the best and the safest practice to obtain your order. So the facility, they have fax machines or other technologies that they use to get written orders. So make sure that you are following that channel to get a written order in the MAR and in the resident's record book. Medication orders are transferred to the MAR from the document with the written orders when the orders are received from the doctor's office or the nurse practitioner's office. So it is important that the order is transferred to the MAR when the order is received. Do not wait until don't wait. As soon as you receive the order, transcribe it, put them inside the MAR. Do not wait until that medication is received. Put the paper first, your orders first, and then wait for pharmacy to bring it. Let's look at the medication labels. So information required on medication labels of medication dispensed by the pharmacy. These are the things you want to see on the bottle or the drug card. So 1, the medication name. 2, the strength of that medication. 3, quantity that were dispensed. So most facilities, they have 30 days quantity in there. That's why you can't be borrowing. Okay? So if you borrow from somebody and they're supposed to have 30 days, you have shorthand them. Now they have only 29 days. So what will happen if the pharmacy delayed in bringing that one that you took from them and gave it to another person? That's why there's the need not to do that. So the date that drug was dispensed, direction for use, the pharmacy that dispenses it. So it should say CVS, it should say Walgreens, Omnicare, and all the other ones that you know out there. The prescription number, the expiration date, equivalency statement, when the brand or medication is different, than it has to be there. Okay. Labeling requirement for over-the-counter. We call it OTC, over-the-counter medications. What are over-the-counter medications? You can buy Tylenol, ibuprofen, aspirin. These are all OTC medications, over-the-counter medicines. You can go to Walmart or anything you can get in the medication in Walmart. They are all called what? Over-the-counter medications. In the original issued, so if there is an over-the-counter medication in the patient's side of the card, this is what you want to see there, the labeling requirement. It should be in the original manufacturer's bottle with the resident name or the labeled by the pharmacy. So let's say Tylenol. Most of the nursing homes, they have the what they call that house stock. House stock. So most house stocks are your Tylenols. Sometimes, what are some of the? I think aspirins and those over. So if it's a house stock, and then it's a PRN medicine for the resident, and it's not part of their drug card. Of course, it's gonna be inside their MAR that is a house stock. That one is very clear on it. Okay, so we're gonna see how medication labels looks like. Okay, in the handout we'll see that how a medication label looks like, and when we come to the skills lab too, we're gonna see. So when we meet on the third day, when we meet, you will see the OTC containers. You look at the labeling, and remember all these things that we've talking about. All the things that we're supposed to see on a label over there. Okay, so it's very important. Directions on medication label from the pharmacy are checked against the order entry in the MAR. So they has to match. Okay, they has to match. If there's any discrepancy between the information on your MAR and the medication label, you have to call pharmacy. Follow your agency, the facility protocol, but the pharmacy have to fix it. Don't go and give the medicine. If a medication is received and there's no entry or information on the MAR for the medication, check the residence record for an order and contact your supervisor. Okay, it's very, very important. So we look at common abbreviations. Abbreviations are a short form of a word or a phrase. Abbreviations are being used less often for medication administration, but you still may see abbreviations. Med aides need to learn, you need to know all these abbreviations and what it means in the medication administration world. On the MAR, abbreviation should be spelled out. Be aware that abbreviation can lead to mistakes if they are not legible. If you can't understand it or see it clearly, it can make you make medication error. Always check with your supervisor if you have questions about an abbreviations. It's very, very important. We will see that in the handout when I switch my screen there. So you need to understand what those abbreviations means. And you're going to see it in the final exams on the third day. We're going to have a written exams that you're going to do for me. It prepares you for the state exams that you're going to take. So remember all those abbreviations and what it means. All right. So I will email the handout to you, you know and understand. Read and read and read until you are able to remember. For me, I memorize most of them. So if you must memorize, please do so. Okay. 6 rights of administrations. Important part you have to know. Safety and accuracy are important to the welfare of your residents. Then why should you know your 6 rights? Because safety and accuracy are important. During a normal work day, a med aide may give many medication to large number of residents, especially if you are working in assisted living. Chance of making a mistake each time a medication is given. That's the reason you have to know your 6 rights. Anyone giving medication needs to stay focused, be organized, and be careful. Follow each and every time whenever you are administering medication. Don't skip to go, okay, I just did it with patient B and A. So why should I go and try to remember my sales right for patient D? It's important. Every patient and the kind of medicine they are taking. So to safeguard the resident, always ask yourself these questions. Which are often the six right? Am I giving the medication to the right resident? Am I giving the medication, the right medication? Am I giving the right dose? Am I giving it through the right route? Is it the right time to give this medication? Have I done the right documentation after you administer the documentation? These are the things that should be popping in your mind. Now, if the medication says every 4 hours, your patient asks for Tylenol, you gave it at 9 a.m. By 11 a.m., she's like, oh, my pain level is at 10. Can I give another Tylenol? No, she cannot. Why can she not? Can somebody unmute their mic and tell me why she cannot? Because the medication label said every 4 hours. You gave it at 9. And by 11, she's asking for another Tylenol. So anybody can unmute themselves and tell me why. Why you can't give it again?
It's not the right schedule time.
It's not the right schedule time. So when you are going through the 6 rights, so ask yourself, is it the right time to give it again? Because it clearly says on the label, every 4 hours. And it has only been 2 hours. So then, what do I tell my resident who is demanding and about to scream and act out and misbehave? I will go to her. Miss Joey, the time I gave your Tylenol was 9 a.m. The doctor said I can only give it every 4 hours. It has been only 2 hours since I gave it. Please give it a little more time for it to work. Okay? And if after the 4th hour and it still didn't work, I will let you have the next dose. Okay? Explain it as gentle and as calm and peaceful as you can. Sometimes they will understand. Sometimes they will not understand. So what do you do after that? Either you get something to distract them. If you know Miss Joey very well, get something to distract them. We'll get administrator involved. So you have to understand the right time, the strength you are giving, right resident. You want to make sure it's the right resident. Each time you give medicines, the resident must be identified. Giving medicine to the wrong resident can cause serious harm. I gave a typical example of the mother and daughter in the same room. They had the same name. Identify the resident who is to receive the medication by using method outlined in that facility. Some facilities will require identify resident with 2 to 3 different ways. While Med-Aid know the resident, this part of routine allows for completion of 3 checks in a careful manner. So do not skip it. This habit will prevent carelessness and the possibility of making a mistake, either now or later. So most adult care homes have the Med-Aid perform identifying steps. So they can use the photo in the MAR and look at the resident. And I gave a very typical example. Some of these photos has been there 15 years. And I promise you, they don't look the same. I look at some pictures and I look at the resident. I'm like, who is this one? Sometimes I go to an unknown facility. I have to go and call someone who I know have been working there and really know the resident. I said, this picture doesn't match this person here. Who is this one here? Oh, this is Mrs. B. Oh, this is Mrs. G. Oh, yeah, that photo is old. They took it when they came here 10 years ago. Like, all right, that's not good. That is not good. But this facility, they don't care. They don't change the pictures. They don't have time to change the pictures, in a timely manner. And then they require that the residents state their first name, last name. What if they are confused? I knew of a resident, when you are calling the next person to them, hey, Miss B, then she will respond. She's not Miss B, but she responded to it. She responded to any name that you will call. How would you identify such a person? Do not ask the resident, are you Mr. James Jackson? They will say yes if they are very confused. Don't do that. They will tell you right out, oh, yes, ma'am. Because if they are very confused, they are hard of hearing, That's another one. When they are hard of hearing and they don't have their hearing aid in. When you say, Janet, you say, yes, are you calling me? But they are not Janet. Because they can't hear you, they responded to the voice that you spoke. So that can create a lot of confusion if the resident is very confused. And like if they have mental stuff going on. Sometimes it's a temporary confusion, sometimes it's their permanent state. So some residents are not able to state their names because they cannot talk. They may be confused or have speech impairment due to illness. So due to speech impairment, example is a stroke person, someone who have had recent stroke in recent times. They cannot tell you. If they start speaking, even though you want them to say something, if they are doing, you can't understand what they are saying. You can't know whether what they are saying is what is there. Even the Med-Aid, when you administer medication to the same resident every day, safety measures for identifying the resident have to be in place. Even if you're going to be with them for 10 years, it's still safe for you to identify them correctly. If the facility has residents who are receiving medication with similar names, be certain to have an alert on the MAR. Date of birth could be a better identifier, So their names can be Lei Chan and Lee Chung. It sounds similar, but their date of birth is different. So in the hospital where I work, we've had patients, when their names are the same, their last name are the same. We have to be very, very careful. There should be an alert in the MAR letting us know. Do not use room numbers, because one day you may come and maybe something has happened in the facility and then they have switched rooms. They have switched the person from one room to the other. But the MAR says that the patient is in room 1D. But that day they've switched her from 1D to 1C. So you can't use their room numbers. There may be more than one resident in the room. A confused resident could be wandered into wrong room. Yes, and that happens a lot. We have wanderers in the assisted living, facility group homes. So somebody can move from their bed and wander, use their walker or cane and go and sit on another person's bed who is not there. How would you know that's the wrong person? You go and give the afternoon medication to the wrong person. God forbid. So you need to have other identifiers. Sometimes, like I said, I have to pull someone who is a CNA there. I know they know the resident to double check with me and make sure this is Mr. Joey. After I've done my other check, I also want a CNA to come and help me identify and make sure I'm giving to the right person, especially someone who has worked there for long. I know they've worked there for long. They know the patients by faces. Resident could have been discharged and made it not aware prior to administering. So most times for me, I go there, I introduce myself to them and I tell them, hey, I'm your nurse. I'm about to administer your medicines. I have your medicines ready here, okay? I ask them, how was your night? How is your afternoon going? How is your evening going? I share pleasantries with them. Then I step out back to my med cart and I start preparing my medicines. It's a good practice. Because if I pull the medicine and I go, the person has been discharged and they didn't give me in report, I've wasted that medication. I don't like doing that. So go share pleasantries, come out and prepare your medications. Some people may answer yes to another resident name, like I said, trying to get additional medication. Even if that's not the intention, they might be confused. They be responding. And I have witnessed that before. One lady, she responded to everybody's name. You said. Mm-hmm. So trying to jump ahead of other people, particularly true if residents do not understand that medication can be different for different people if the residents are confused. So you have to be aware of all these things that can happen. If a Med-Aid prepares medications away from the resident taking them, it is important to keep the MAR with the medications until the medications are taken, so that the wrong medicines are not accidentally given to the wrong person. It's very important. Important that MedAid keeps identifying information with the medications from the point of preparation to the point of giving to the residents. It's also very crucial. So I close everything. I cover my medicine. I take it to the room. I give it to the person. It's important to do that. MedAid might always refer to the MAR when giving the medications. Never give medications from memory. This one, I've done that before, but I had to stop at some point. As smart as I am, I memorized some of the patients' medication in one of the nursing homes that I worked for a very long time. I memorized all their medicines. I had to stop because let me tell you what happened to me. Now there was a medication change I didn't know. When I went that night, in report, the nurse didn't tell me there was a medication change. So because I had done from memory, I put what I put, and when I opened the computer, there was a medicine change. And thankfully, I had not given it. Yes, I'm telling it as it happened. Thankfully, I had not given it. So I'm like, why didn't this nurse tell me that, oh, they've added this to the medicine? And then I remembered, Rosalind, you're supposed not to do from memory. You're supposed to look into the MAR. And I'm like, yeah, right. Even if she didn't tell me, I'm supposed to look from the MAR, not from memory. So I caught myself that time and I stopped doing that. So it's very, very important. I learned it from somebody. I learned that bad habit from somebody, And so I had to catch myself just in time to give the right medications and not rely from memory. So it's very, very important that you know all these things. During the 3 medication check, MedAid will not only make sure a particular medicine is labeled for a particular resident, but during that process, you make sure the med name, the dose, the time, the route, and the label is matching your MAR. Very, very important. I'll keep repeating it throughout. You hear. So check the name, the dose, the time, the route on the package against your MAR. When the container is removed from shelf or a drawer or a storage place. You check the name, the dose, the time, the actual drug package or the unit dose label against the MAR. As medication is poured, the package is open, before you place it in the medicine cap. So the medicine cap, the bottle, whatever, if the label is removed, don't give it. That's a big no-no. That's a big red flag. So check the name, the dose, the time. When the medication is returned to the shelf or the storage before it is open, just prior to giving it, you have to check it. If you are in doubt, go ask. It's very important. You may feel like you are overdoing it by checking. No, there's nothing like overdoing. It is you doing your due diligence to prevent medication error. Do not be lured into unsafe practices. As you go and over the years, be like, I'm so confident, I'm comfortable, I know this, I got this. No, you don't got this. Go according to as trained and as taught to prevent med errors. Okay. So you want to reduce medication errors as much as, you punch the cards, or you want to make sure you are doing the right thing. Be alert for similar sounding names for medications while making right medication choices. Best and safe practice is never give a medication prepared by someone. Yep. If someone pulls the medicine and say, go give it, don't do it. Don't do it. You didn't see the drug card. You don't know where they are pulling it from. and anything happens, who gave that medication? You did. It's on you. So don't let any nurse pull anything and say, hey, go give it. Don't go and give it. Say, no, ma'am, please go give it yourself. Yeah. Medication aid must make sure the right dose is about to be administered by comparing medication label to the mark for the exact amount. So, for example, if the digoxin, especially the digoxin, 0.25 is to be given, and the supply is 0.125, 2 tablets must be given to equal the right dose. It is best for the mouth to stay to give 2 tablets of the digoxin, 0.125 m. You see? Now, sometimes, these pharmacists can be lazy, and sometimes they can omit that part. So we know that the strength the person is supposed to receive is 0.25. However, the tablet each has this strength in it. So that's not 0.25. It means the patient requires 2 pills. So if the instructions is not clear, call pharmacy to prevent you underdosing the person, not giving the right dosage. They are not receiving the right strength for them to get the right effect they need in their heart. That is to be caught. We are the final eye. You, the med aid, we, the nurses, we are the final eye. We catch the errors that the pharmacists make. Yes. We catch the pharmacists that the nurse practitioners and the doctors make. We are their second eye. Always remember that. To help prevent medication dosing errors, a 0 should always precede a decimal, but it should not follow a decimal. This is very, very important that you pay attention to it. For example, if the 0 is not present in the example above, the decimal might be missed, and instead of 0.125, someone is going to be taking it as 125 milligrams. That is way killing. You're going to kill that person. If anybody should receive 125 milligrams instead of 0.125, that patient will be dead before EMT arrives. That's why there's a need to make sure you see the 0 before the decimal. If a medication is ordered 1 milligram and in the MAR is written at 1.0, somebody can mistake it for 10. That's why a single number should not have any trailing 0 behind it. Very, very important. And we catch these errors. We are supposed to catch these errors. Don't put any 0 behind any whole numbers. That is not supposed to have it. If it's a 10, it's a 10. But if it's a 1, don't go and put 0 behind a 1 for someone to go and read it, because not all eyes are the same. Somebody needs an eyeglasses before they can see that there's a 1.0. It's not a 10. So if you are the 1, this is where that error can happen. If the doctor gave you a verbal order and you are writing it on the paper or the order sheet, and he said 1, but when you are writing, you write 1 and then you put 0. Someone will come and read it and give 10. That is crucial. Somebody can die from this. So don't do it. Another common right dose error is for people to mix up the abbreviation of the ml for milliliter and the abbreviation for mg for milligram. So milliliter is different from milligram. Milliliter is for liquids. Milligram is for tablets. Very, very important. 1 ml dose does not equal 1 milligram dose. It's not the same. It is not the same. Mixing up those abbreviations can result in dosage errors. It's very, very important. We're going to look at the handout very soon. So it's very, very important that you know all this. The right route. What method, through what path is this resident receiving this medication into their body? So giving it by mouth, giving it inside the ear, giving it in the eye, applying it to the skin. These are all the routes. The route of medication will be noted in the MAR. If it is not there, stop and ask somebody. Stop and ask your administrator if you are the supervisor. Do not make an assumption and ask how to give a medication. Don't do that. So we have the oral routes, number one, oral route. So the skills checkup that we are going to do, some of you are going to do the oral, sublingual, topical. We're going to divide it. So refer to oral or PO. PO means by mouth. This is an abbreviation. When you see this in an order, it says PO. It means by mouth. Medication in the mouth and is swallowed. So certain people cannot take oral medication. People who cannot swallow well, such as residents who do not have gag reflex and choke easily, they are confused or refuse to take medication by mouth and not to have anything by mouth. So you have to remember that. If the order says NPO, it means nothing by mouth. So what the doctor is saying that do not put anything inside the person's mouth. So when a resident is going to have a procedure done, maybe they are going to have a barium swallow test. By midnight, there will be before that day, the doctor will put an order in the system. If you are working with a computer, the electronic system in the facility, they will say that April 2nd, at midnight, this resident should have nothing by mouth. It's going to say MPO, nothing by mouth. So it means he or she can be eating, taking medicine, whatever. By midnight, everything should cease. Everything should stop. Perhaps doctor can say only medication can be given with a small amount of water. Sublingual means is under the tongue. So when you put a medicine under the tongue, it allows it to dissolve and get under the tongue. So it dissolves quickly and get into the bloodstream quickly. Residents they are not supposed to be swallowing it, chewing on it, smoke, drink while the tablet is inside their tongue. So they have to allow it there for some minutes for it to dissolve. Then after that, they can drink water. We have the topical route. This is for treatment. You put it in the entire body or some part of the body. This can be a variety of medications. It can be a drop, it can be ointment. It can go on the eye, it can go in the ear, it can spray in the nose, in the throat, suppository in the rectum. But everything that is topical is go on top of something on the skin. So areas for topical medications: your skin, your eye, your ears, your throat, your vagina, the vaginal area, the rectum. Some topical medications affect the entire body, such as a pain patch. When you apply a pain patch to your body, you will begin to feel the effect immediately. Yes, you begin to feel, if it's cool, you feel the cool breeze. And if it's having any pain recepting something, it will start, dispatching into your cells immediately. We have the inhalation route. So this goes to the lungs through the inhaler or the aerosol. We will see that in the lab. We will see some of the sprays. We have the spacer that goes between the tip of the inhaler for them to those with asthma, those with COPD, those with breathing issues. They have the inhalers they use. So we have different types of inhalants. You see some And then we have the subcutaneous. It's delivered to the fatty layer of the body using a syringe and a needle. So what is the right time? Make sure you give the medication at the right time. The time to give medication as it is stated in the MAR. When you go to individual adult care homes, they have standard times for administering their routine medications. If a medication is to be given BID, it means twice a day. So the facility may set it at 10 a.m. and then 10 p.m. Some medication times start from 8 a.m. Some start from 9 a.m. It all depends on the facility and how they have structured. When a medication is ordered before, abbreviation for before is AC, or after, the abbreviation for after is P.C. It should be given 30 minutes before or after. All this can be found in your MAR. If it says give Tylenol 325 milligram before meals, it will not use the word before, it will do AC. You have to know what AC means. If you say PC, you have to know what it means. AC means before, PC means after. Take note of these very ones. You will see them in your exams. All right. Medication, because these are common ones that you see in your med labels, in the MAR. Medication that are given once a day should be given at the same time each day to keep the right amount of medicine in the resident's body system. So set times within a facility helps to prevent mixed or double doses, which can be harmful to the resident. So the medication aide should not give the medication too early because it could be too much medication in the system. So if you work a night shift and it says that 6 a.m., between 6 a.m. to 7, we have 1 hour window before and after. So if there's a 6 a.m. medication, your facility can let you know. You can give between 5 a.m. and 7 a.m. before and after, 1 hour before, 1 hour after. So between 5 a.m. and 7, you can administer that medication. Don't do it at 4:30 because you have too many residents to give medicines to. Don't do that. Okay, don't do that. Always work between the windows that has been given by the facility. It is very, very important. Don't give it too early. It's going to be too much in the resident system. You think you are saving time, but you are harming your resident. Don't do that. We want them here for the long haul so we can keep our jobs and make money. All right. Medication needs to be given within a set amount of time to provide the resident with the correct dose of medication at the right time that allows the medication to work as it should. So, for example, if a medication is fighting an infection and doses are given at time spans, between doses too far apart, the infection may get worse. So, and then it can make treatment very hard. So, if someone is having UTI, urinary tract infection, okay, and then they've been prescribed nitrofurantoin, okay, and you are not giving it at the right time, it may prolong the UTI from the resident from getting healed. So be sure that you are keeping to the time. It's very, very important. The window of time for the medication to be given is 1 hour before and 1 hour after, like I said, and it should be done between that designated time. If a med aide is unsure about giving the medicine because it's outside the designated time frame, that is a medication that is missed, or the pharmacy brought it late, okay, check with your supervisor, check with the nurse or the pharmacist, follow the facility protocol for that, okay. If you are to still give it, go ahead and give it. Never omit a medication without contacting your whoever is your overall boss. Never do that. So he came 1 hour late. He came 30 minutes late. Ask the nurse. Ask the doctor. Don't just assume he came late. So let me just omit it so that she will take it the next time I'm giving it. Don't do that. Please. Always ask. Timing of medication in relation to meals. So if it said give it before meals, it means they are supposed to take it 30 minutes prior to the meal time. If it says after meals, then it's supposed to be 30 minutes afterwards. Always remember that. Always check the time, the last dose of a PRN. PRN means as needed. PRN means as needed. Remember that you're going to see it in your exams. I'm giving you some tips here. PRN medication means as needed. So check the last dose before you go and give again, before you create an error. If the person is pressuring you, go and check the last time you gave it. That's why proper documentation is very crucial. And that's the next one. May have heard people say, if it's not documented, it is not done. As a med aide, as a new med aide coming on board, always remember this phrase. If I don't document it, it means I didn't do it. And in the court of law, we have nurses and we have the RNs, LPNs. They do what we call utilization review. It's a job that people do from home. They go through all medication documentation from one facility to the other, and they check it against, especially when there's a lawsuit. Whatever they will take from you, it should be in the documented. That is your legal, that is your gateway to keep your license. I can't stress this enough. If you do not document it, no amount of words that you will say will vindicate you. I promise you that. Even if the administrator is your best buddy, is your bloodline, is your family, if you didn't put your information on the document, they cannot save you. The state will come after your license. It is important. If documentation is not completed, there's no way to know the medication has been given. Without correct documentation, there is a danger for the resident. It means the person can receive double dosing or underdosing. It can harm them. They can die. Is that what we want for our residents? We want to keep them alive so we can keep our jobs. So do the right thing. So document immediately. Don't wait. Oh, let me go eat lunch. When I'm done with lunch, I'll come and document. Don't do that. The tendency for you to forget what you gave is very high. Because when you leave that med card, someone may engage you talking. You might forget so many things. And as we are aging in our career, the likelihood of forgetfulness is very rare. It is real. So document. Do not chart or document medication before the resident takes it. It is called pre-charting. And we have what we call pre-pouring. You pour everybody's own into their cup, label it A, B, Z. Don't do that. It can cause errors. Don't do that. Don't create conveniences for you that can create harm for others. Don't do it. Always chart after the resident take their medications. Whatever happens after that, chart it. After administering a PRN medication to a resident, MedAid must also document the date, time, the reason the medicine was given on the MAR. The effectiveness or result of the PRN is documented later when the effectiveness can be determined or reported by the resident. So if their headache has stopped, you have to report the effectiveness of it in the MAR. Immediate, clear, and accurate documentation shows the right dose of the right medication was given to the right resident at the right time, on the right date, through the right route. Remember that. If this does not happen, I promise you that one can lose their license. You cannot go and stand in any court law and say, oh, but I did this. No, they don't care about that. What is in the paper is what they are going by. And it says it was not documented. So whatever you say doesn't hold anything. So looking at the handout, we've already spoken about medication name, the strength, the dosage, the route, the directions for it, the reason for it. So let's look at an example here. So we have the drug name Lasix. Okay. This is the strength. Okay. The dosage says give 1 tablet. Okay. And then it says the route is by mouth. Frequency is once a day in the morning. That is how a complete order should look. This is Tylenol, 325 milligrams. It says give 1 tablet by mouth every 4 hours as needed for pain. And for us, we have in the hospital, our electronic MAR has the pain scale, because if it is a pain rate of 1 to 3, 1 to 4, give Tylenol 325. If they say the pain is from 7 and up, we give oxycodone, something stronger than Tylenol. So your facility will definitely let you know. There should be a range. The mouse comes with a range. So when you are giving medication, when they are telling you, I have a headache, explain to them the pain scale. If that scale is what the MAR is saying. Okay, Miss Joey, I'm going to give you a scale. Tell me where your pain is at. 0 means that you have no pain. 10 means you are in excruciating pain. So on a scale of 0 to 10, give me a number. Oh, it's about a 5. Is a 5 under Tylenol? Then go give 2 Tylenol. Is it 6? Is that under oxycodone? Go pull oxycodone. So that should tell you how you get the medicines out. And then we have the types of orders. So we have the routine, the PRN, the one-time order, the start. So the handouts go more detailed to explain it. That's why I didn't talk about it in the main slide. Now, when it says routine, what is a routine? Routines are detailed order for medication and is given on a regularly scheduled basis, such as every morning at 10 a.m. That's a routine. The reason the medication is being administered is usually in the resident history. So when you read the resident care plan, about them, you will know that, okay, they have CHF. Okay, that's why they've had blood clotting issues and whatever not their diagnosis are. So they are taking digoxin, okay? They are taking Lasix because they have CHF. They are taking Tylenol because they have chronic pain. So you should know all that. That will give an idea why this person is on. So that when the person asks you, why, can you remind me again why I'm taking atorvastatin? Okay, I can get you the supervisor to come and explain to you. You can get them to come and explain to them. Or if you've read that in their chart, say, oh, it says that you have high cholesterol in your medical records. And if you need further explanation, I can get the nurse for you. You get the nurse supervisor on the line and let them talk to the residents. That's how you do. We have the PRN. So routine means it's something they are taking on daily basis, either once a morning or twice a day, morning and nighttime. Those are their routine medications. PRN, like I've said, means as needed. So PRN means whenever it's needed, whenever it's necessary, whenever they demand for it. And, you can see evidence of what they are asking. Okay. So it's for periodic times It can be laxative when they are constipated. 3 days they have not had any bowel movement. So as a PCA, as a med aid, you should know your resident. Every day we should be recording their bowel movement. So if 3 days they've not recorded, you all have not recorded any bowel movement, yes, they need a laxative. And in their MAR, it is going to say, give them a doculus, enema, a magnesium, something in that nature that makes them go. So you go by that. That's your PRN medication. You have to understand the time interval. Every 4 hours, every 6 hours, you know. So the med aid, you have to know, what are they taking it for? Is it for pain? Is it because they are coughing? All right. So med aid can return and give medication in 1 hour if it's still needed. Medication should be, the med aid should report the pain to supervisor to be evaluated further to see if a different medication or dosing is needed. So yeah, if it didn't work after 4 hours, they are still complaining, let the supervisor know, let the RN know, let the doctor know. We have the one-time orders. Some medication can be given once, depending on whatever the medical condition is happening. And then we have the start order. This medication, it needed to be given immediately. The start order must be clearly written on the MAR that tells you the resident medication, the dose, the route, the time. Do not give medication that do not have a clear written instructions. Okay. So tomorrow I may give you activity about this. I'll give you some sample and then you tell me whether it's a complete order or not. So take note of this. So Risperdal, 2 milligram, give 1 tablet by mouth. Raw pan liquid, 15 ml by mouth, every hours as needed. Now look at this very well. Every hours as needed. Everybody unmute your mic and tell me, is this a complete order? Yes. The Riopan liquid 15 ml by mouth every hours as needed. Is that a complete order? Yes. What do you think about this first one, the second one here? Riopan liquid 15 ml by mouth every hours as needed. Is that a complete order? What do you think?
Yes.
Is there something wrong with this order or it's complete order? Remember, it's a PRN medicine. It says as needed. When you hear the word as needed, it means PRN. It's not a routine order. Miss Jamie, do you think that is a complete order? Miss Tina, you are the one that spoke. You said yes, right? Did you say yes? Somebody said yes. I want to know who said yes.
I said yes.
Oh, okay. Mama Jamie, I want to hear from you. Is that a complete order? Yes, I'm listening. You see that as a complete order? Yes. Based on everything we've said so far, do you think that's a complete order? Is Miss Jamie with us? Mama Jamie?
I'm calling her to check. See if she's having.
It looks like she's not at the desk.
Yeah, she's not answering the.
Resume. Okay. Okay, so everybody can see my screen. So let's back to. So okay, so I'm going to ask. I already asked Miss Tina when you were gone. So let me ask you. The second order, it says raw pan liquid ml by mouth every hours. Do you think that's a complete order, or there's something wrong with this order, Miss Jamie?
Yes, there is something wrong with the order.
What do you see? What do you see wrong?
There should be a 1.5 instead of the 15 because that could be an overdosage.
Is that all you see? What else do you see might be wrong with this order?
The period is after the L.
Okay. What's wrong with that?
The period. I'm not understanding.
You are saying the period shouldn't be there? Is that what you're trying to say?
Right, right.
Okay. What else?
But it says by mouth every hour as needed. So you have to give it the 1.5 by mouth every hour as needed. It's an as needed medication.
Okay. So actually the strength is there's nothing wrong with the strength. So it's not a 1.5 thing, it's just a 15 ml.
Okay.
However, what is exactly wrong is that it says every hours. But that is where the problem is. It's supposed to tell us whether it's every 4 hours, every 6 hours, every 8 hours, or every 12 hours.
Okay, so see, this is where I'm confused because I personally, from doctors, have gotten medication throughout my life that says every hour as needed. So that would not be a red flag to me, even though today you're telling me that's a red flag. There is medication, and I know me personally, and even with my mom, when I was taking care of her, she has received medication that says every hour as needed. So if she took a pill or liquid, either one, whatever the medication is, at 1 o'clock, but at 2 o'clock she was doing fine, and then at 3 she was saying that she was feeling some pain, then I would give her whatever that dosage is. So that would not have been a red flag. I was going back to what I wrote as a note that 15. Let me just say the 15 would be too much. There has to be a decimal somewhere in that number.
Now, I see what you're saying. Now, every hour is different from every hours. This one has an S with it. Do you see the difference?
Oh yeah, that's what I was saying. I did say, I said it should say by mouth every hour as needed. Maybe I should have clarified a little further and not with the S on it.
This is where the error is. This is what I wanted you to point out. So as long as it say hours, then I need a number for it to say 4 hours or 6 hours or 8 hours or 12 hours. But if it's every hour, that I know that it's talking about 1 hour. You get it?
I got it.
Yes. So there are liquid medications that is 10 ml or 5 ml or 15 ml or 30 ml.
Okay. So earlier when they were talking about the decimal point, right?
Now let me explain that part for you.
Okay.
Let me explain where the decimals comes in.
Okay.
Now in the tablet medications, we have 0.5 milligram.
Okay.
0.5 milligram is the same as half of a tablet. So
Okay.
if this 0.5 is being transcribed, if I'm writing it, if doctor calls me, I'm on the phone with the doctor, and the doctor said, okay, you are going to give this digoxin 0.5 milligram of the tablet. Now, as I'm writing it on the paper mark, I'm supposed to write exactly 0 and bring the point and bring the 5.
Okay.
I'm not supposed to write just a point and leave the 0 out and bring the 5.
Okay.
This is what we are trying to teach our med aides and every nurse, that when you are transcribing an order, make sure if there's a decimal, bring a 0 before the decimal.
Okay. Okay.
Bring the 0 so there'll be clarification for whoever will look at it later. So they will not take it as another number when it's actually there's a decimal before that number. And if it is just a single number that the doctor said, if the doctor said 5 milligram, don't write 5 and write a decimal and write a 0, because someone might mistake it for 50 milligram.
Right.
So if it's a single digit number that you heard in your ears, to write 5 milligram, just write 5 milligram. Don't go and write 5.0.
Right.
There is no need for a trailing 0 with a whole number when the doctor didn't say it's a 0 point something milligram.
Right. Using the fraction.
That's right. So you have to transcribe appropriately, so nobody will mistake what you've written for a whole number and go and give triple dose and kill the person.
Right. So
does it make sense now?
Yes, it makes sense. But just so to rectify my own error on the Riopan and to make sure I have that understanding, even in liquid, if it is liquid can also be in the fraction form, right?
Yes, it can. Okay. That's right.
Okay.
Yes, liquid can be in the fraction form, and always listen for what the order says.
Right.
So if it's in the fraction form, make sure you are putting the 0 before that decimal, so that somebody will not mistake it for a whole number when it's actually not a whole number. Absolutely. This is where we are trying to, state clearly. If it's a decimal, there's a decimal. Make sure you are putting the 0 where it belongs, in front. Don't go and put it after. If it's a whole number, omit every 0 after it. If not, you are going to have somebody dead.
Right. Okay. And we don't want that. Okay.
And we want to avoid that at all costs. We don't want any accidental death on our hand where we will live with the guilt for the rest of our lives.
Exactly.
Does it make sense?
Yes, absolutely.
Good. Okay. Any questions on that before we move forward? Miss Tina, any questions? I want to make sure everybody understands that part.
Yep, I definitely understand it.
Good. All right. So the next one says Aricept, 1 tablet by mouth at bedtime. Is this order correct? If not, what is wrong with it? Let's start with Miss Tina. What's wrong with this order? What do you think is wrong with this order? Aricept, 1 tablet by mouth.
It doesn't say the strength of it.
It doesn't say the strength. Miss Jamie, do you agree?
I do agree.
Okay. So always have that eye. If they are talking to you on the phone, giving you orders, a med order, and the doctor said, oh, the nurse practitioner, give that Aricept, 1 tablet of it at bedtime. Okay, you write that down. What is the strength of this tablet? How many milligrams of it am I giving? You need to clarify that with them. It's very important. Tylenol, 2 tablets by mouth every 4 hours as needed for shoulder. Is this order correct?
The zero in front of the point? No.
Well, Tylenol is an over-the-counter medication, right? Are we speaking of over-the-counter medication?
Tylenol is an over-the-counter medication, and it is also a prescribed medication. Yeah.
And it's prescribed
The strength again?
The
So,
strength again, that's what I'm looking for. Okay. So Tylenol comes in 500 milligram. Tylenol can be 1,000 milligram. Tylenol can be 325 milligram. So which of it are we giving here? Right?
right now we don't know.
Right now we don't know. So it can be a mad error if we just assume anything and go give anything, right? We can be overdosing the person. And especially if you have a patient that has issue with their liver, Tylenol is a big deal for them. Okay, because all medication or almost all the medication metabolized inside their liver. Did we know that? Did everybody know that?
Yes.
The liver is one of the most important organs in the body.
Yeah.
Because of drugs. So if someone who is an alcoholic and has abused their liver over the period of time with alcohol, giving of Tylenol has to be given with extreme care. So if this medication or that is given and they don't give you the strength, you don't know how many you're going to give to this person. That can damage their liver, which is already damaged anyways, right?
Rosalind?
Okay.
But I do have a question, and I'm sorry.
Yes, ma'am.
I always kind of think outside of the box or look at other scenarios. Just going back to over the counter, it will say OTC, right?
Yes.
The doctor is prescribing an over the counter medication. So if the doctor prescribed a Tylenol 2 tablets by mouth, will they also, they'll put OTC on there, but will they also say what that dosage should be?
Yes.
Okay.
It's going to say 500 milligram.
Okay.
It's going to say 325 milligram, give 2 tablets. Okay.
Whether it comes from the pharmacy or whether you purchase it off of the shelf, correct?
Yes. So in the facilities, they have what we call house stock. So house stock, they usually have the 325 milligram house stock, and they also have the 500 milligram house stock. So based on the MAR of the patient or your resident, you can go and take the one that is the 300 and 325 milligram house stock or the 500 house stock based on what is written in your MAR.
Okay. Okay.
Does it make sense?
Oh yeah, it makes sense. I just wanted to.
Yeah, so I work with a facility whereby even the Tylenol was part of their drug card. But it's not all facilities that do that. So the majority, I would say 99% of the facilities I work full-time or as a travel nurse, we go for our Tylenol from the house stock containers.
Okay.
So go read your MAR, know the strength you are going for, so you don't go and take 500 milligram instead of the 325.
Okay.
You get it?
I got it.
Yes. So most times, to what I've seen is that if a doctor says 500 milligram, the person is taking just 1 tablet or they are taking 2 of it. And then if it's a 325, they are always taking 2 tablets. Most of the MARs I've seen. But again, you always want to make sure that you are reading.
Okay.
So medication label, as we've already spoken about from the other thing. So know the resident's full name, the right resident, the name of the medication, the strength of the medication and amount to be given, which is the route dose. Directions how to take the medication, which is the route. Direction about the time when to take it. That's the time. And how often to take it. So is it morning? Is it afternoon? Is it evening? You know, is it saying twice a day? Is it saying 3 times a day? Is it saying 4 times a day? You got to know that. It has to be written boldly and clearly. The name of the person prescribing it, who is the doctor, the date they issued it, the expiration date, especially the expiration date. Do you know how many facility has been fined by the state because they were given expired meds? Do you know?
Probably a lot.
Because they were given what? I didn't catch that last part.
Yes, they get they get they it's a lot. I promise you, they get tagged a lot. Nurses are not looking at these bottles. They are just popping pills, popping pills. Don't be like that. As you come on board, don't be like that. Always look at the expiration date. Okay, the facility can be fined big time. We are the final eye. Those of us who give medicine, we are the final eye to all this. Okay. The pharmacy that is prescribing, their serial number has to be there. The pharmacy address has to be there. The pharmacist, the quantity. Like I said, some facilities, I realized during my travel nurse duties, some of the facilities, they gave 60 days quantity. But most of the facilities, you will see a 30-day. Most times, it's a 30-day quantity you see. Okay. So sometimes there are auxiliary labels that say shake well. When it's a liquid, it will tell you shake well before giving it. You have to read all this and then the warning labels. You have to read equivalency statement when the name of the medication differs from the name. Sometimes the name differs, but it's the same medicine. So it will put into bracket. If it says Tylenol, and then it will put into bracket acetaminophen, so that you won't think it's a different thing they are saying. All right. So let's look at how a label should appear. So your pharmacy center, this is their address, this is their phone number, and this is the serial number that they were talking about, DEA. Dr. Sullivan was the one that prescribed. This is the prescription number, and this is the patient's name. It says give 1 tablet, 5 milligram by mouth once daily at 6 p.m. Quantity is 30, so you can't borrow and give it to another person. Don't do it. Okay. And then we have the next drug that says Coumadin. Okay. Or warfarin. You see, Coumadin is the same as warfarin. That's another name for it. So it should specify for you 0 refills. Discard by, this is the expiration date. You have to be very careful who is dispensing. This is the pharmacist's name. It's very important. All right. These are some of the abbreviations that we have to memorize. You need to know these things. It's very important in your journey as a med aid. So if you see GM, it means gram. If you see MG, it means milligram. So I'll leave you to memorize this part, right? It's very important that you know them. Know how they are spelled teaspoons and then the tablespoons. And what they have for drop, an ounce, PO by mouth, PR per rectum, OD right eye. It's very important. These things, you just have to memorize them. That's all I can say. You just have to memorize them. I memorized them. That's how I was able to learn it. Okay. It will come in handy for you, especially on these labels, because you will see them. If you see QD means every day, BID means twice a day. And when you memorize them, it becomes second nature to you. OTC, there it is, over the counter. And MAR means medication records. TID means 3 times a day. QID. If you see QR, it means every, QHS means at bedtime. AC, before meals. PC, after meals. I promise you, this is on your test. You're going to see it on the state exams. These ones, the common ones. the everyday ones. So memorize them. You will pass your state boards, your exams when you memorize them. You can't get them wrong. You should get them right. So a method used during medication to safeguard the resident before administering, you must ask yourself the 6 questions, the self right. Am I giving the medication to the right person, the right medication, the right dose, the right route? Is it the right time to give it again? Have I completed the right documentation after I have given it? So you identify your resident, make sure that is the right person. Use the facilities, whatever they have given you for you to use. Okay, use that. If they are telling you use photos and you think the photo doesn't look like them, go look for another identification for that, so you are not in error. Ask somebody who knows them. That's what I do. I make sure I'm giving it to the right person. So the right medication, the dose, the route, and the time. And after the person has taken their medicine, I come and document immediately. I don't wait after lunchtime. Don't do it. Don't do it. So this is showing you the decimal points and the zeros. Okay. This is showing you so we see 0.45 milligram. And it tells you that 0 is needed in front of the decimal. So you have to put it there. It is needed. So when they leave the decimal out, then you know that something is wrong. This one is the correct way of putting it. And then when they put 0, then 4, and then point in between, 0 not needed. You don't put the 0 in front of a number like that, because that's not where the decimal is, or the decimal is starting from. It makes it confusing. Okay, it confuses them. And then when there is an 8 milligram and then you put 8.0, that is also, somebody can mistake this for 80 milligram. Don't do that. They can overlook it and see an 80 instead of 8.0. So it's very, very important. All right. So the common routes, we have the oral, which is by mouth, you swallow. Buccal, meaning they put it in between the cheek and the gum. Sublingual means it goes under the tongue. The eye means it goes in the eye pocket. We will show all this practice when we meet in person. We have the ear, the nasal, which is the nostril, the inhalant, meaning it's going into the lungs. The towers also go into their nostril. We have the transdermal, which are the patches. We put it on their skin. If it's topical, it can go on the skin. It can go inside the hair, in the scalp. Vaginal means we insert it into the vagina. Rectal means it goes in the rectum. Subcutaneous is a syringe. All right, so the common forms for medication. So we have the tablet, which is hard, compressed. We all know how tablets look like. So when we meet, we will see all those tablets. Some are oval, round shape. Some have enteric coating around it for delay release. And sometimes the tablet will tell you, do not crush it. They have a reason for saying do not crush it. The time that your resident can no longer swallow pill, but he says do not crush it, what would you do? Call the doctor. Tell them, hey, this person can no longer swallow. Then they will know what to do. They will change the medication format, or they will tell you, crush it. We have the capsule that comes in a gelatin container. Some are soft, some are hard. It dissolves quickly in the stomach. And we have our liquids, medications, the syrups, the laxatives ones. Some of them are mixed in alcohol and all that. We have the suppository. It goes into the rectum. Sometimes it's for fever. When someone has a fever, they cannot swallow something. They have to go through the rectum. Sometimes it's a vagina medication. because the person might be having yeast infection and it has to go through that route. And most of these suppositories are supposed to be in the refrigerator. So always read and say, if he says do not refrigerate, don't put in the refrigerator. If he says keep in refrigeration, put it there. Sometimes it says put it away from the light. Make sure it's not in any direct contact with the light. Put it under whatever covering it came. We have the inhalant that goes through the nasal or the inside the mouth, and it goes inside the lungs to help with oxygenation and all that breathing. We have the topical. It goes directly on the skin. So we have ointment, lotion, paste, cream, shampoo, patches, powder, aerosol sprays. That it goes on there. So any questions before we continue?
No, ma'am.
Miss Jamie, any questions?
No.
Okay, so looking at this label here, looking at this document, so accident in a long-term care where you're gonna be working, you see in their records their name, date they were admitted. You know, this is a typical example. You need to read all these things. It's very important. It makes you know their diagnosis. Okay, primary, secondary diagnosis, onset. It checks all the things, whether they are continent, whether they are incontinent. Do they have colostomy? Do they have catheter? All this will be checked. You will know. This makes you have the full picture of your resident. So when you are giving them PCA care or med aid, you know what you are dealing with. Why? Because you have read their chart. Okay, you know the list of medications they take is all there in their record. All right. This is how a medication records look like. So here, this big space will have the medication order. And this is a 30 up to 31 days of recording. The time goes here, whether morning, afternoon, evening, night, it all comes here. The time will be here. This is when they are using the paper record. This is how it looks like. So depending on the facility where you work, you will see these things. So charting of the month. So you follow all these things and they will orientate you. You know, who is the resident, the physician, the name will be there. You have them all filled out, but you need to understand their room number will be there. The day they were admitted, it will be there. Their medical records, it will be there. So you know when to call the doctor. Their phone numbers is in the MAR. You're not going to be running around for it. You know where to go and get your doctor's number and call them in the case of when you are passing medication and you observe something. And then you have the key that tells you, the code where you put injections. It tells you. Okay. This is the nurse medication notes. This is where you're gonna be charting. You're gonna put your initial and you put your title. You make sure you put your title. So this one has the nurse's signature. But as a med aid, there will be a row where you put med aid there. Because you can't be reporting as a nurse when you are not the nurse. So you have to put your title. So the MAR, based on the facility that you are working, they will give you an appropriate MAR where you will put your title as well over there. You see, this is a filled one. So they showed us the empty one. Now this is filled. The patient name, the date of birth, the day they were admitted, it's an adult care assistant living. Okay. It tells you the doctor's name, the address, their relative. So in the case where the care plan says that if they are refusing medication, call the designee, then you know who you are calling. Ben Clayton is who you are going to call and call them, tell her, hey, I'm a med aid, I work in this facility, I have these patients, and you are listed as the relative that I can talk to. He has been refusing his medication the whole day. So he says that we should call you in a situation like this. Then you give them that information. They will come over, they will know how to talk to that person. You see, their diagnoses are here. All their diagnoses are here. All the things that pertains to them, this is the care plan. Their continent of bowel and bladder, their ambulatory, it means they can walk with their walker. They are not wheelchair bound. You know, it tells you whether special diets, whatever they have is going to be there. Whatever they put there is going to be explained. And these are their medication. They are Dilantin, Acupril, Zithromax. You know, it tells you what they are taking it, when they can take it, what they are taking it with. AC, BC. You see where it says AC. So if you don't know what AC means, you are in trouble. So that's why there's a need to memorize this abbreviations thing, because you're gonna see them. You're gonna see them. And this is how. So you see, someone gave a hydrocodone on this date, on the 3rd. This is their initial. Somebody also gave on the 9th. This is their initial. If it is discontinued, they put it there. Order change. See below. You know, so there'll be a note where they explain why the order has changed. Who changed it? The doctor. You know. So this is how the medication is. You see how they have filled it with the names. Take 1 tablet by mouth once a day. Now, Lasix, 40 milligram. Take 1 tablet by mouth once a day. Is this a PRN medication or a routine medication, Miss Tina?
Routine.
That's correct. So it's a routine. What makes it a routine? Why did you say it's a routine?
Because it's being given every day. It's not something
Every
that's going
day.
to stop.
Correct. So this tells me that you're going to pass your state exams. Right there. I know you got the content correctly.
Mm-hmm.
You got your facts right. It's a routine because it's saying what every day. It's a scheduled medicine. It's not PRN. PRN will say what as needed, right?
Mm-hmm. Yes, ma'am.
That's how it goes. So this is how an order is, as their name. Make sure you know their allergies, what they are allergic to. It's very, very important as a med aid to know your patient's allergies. So that if mistakenly doctor prescribes something that it was an oversight on them, you will catch it. Remember, we are the what? The last what? We are the last what? Checkpoint.
The last, yeah.
We are the last checkpoint as a med aid, as a nurse. We are the last checkpoint before the patient or the resident take their medication. So you see the notes here, the date, the time, the medication, the route, what reason, why was it given? The initial is here. The result, effective at 12 p.m. The initials is here. So it's important you know all this. All right. All right. All right. So when we meet in person, I may have some of the MAR, and then you tell me how you feel it. You feel some for me to see. As you do your skill checkoff, you go and put it on the MAR for me. It's part of your skill checkoff. So I will know that you have understood where your routines are, where your PRNs are. I would like to know all that. You'll be able to check all those things for me already. All right. So we are looking at the medication. We are looking at the medication record sheet. So you should be able to transcribe orders correctly, use proper abbreviations, calculate, stop dates correctly. You should be able to transcribe your PRN orders appropriately, copy orders correctly and legibly. need to write legibly so that the next person would be able to see your handwriting. So there will be no medication errors. Describe the responsibility. Okay, so that's what I showed you. The FL2 is what has all the patient's records from the day they were admitted. So every med aid and the PCA must know what the FL2 is, to know whatever the doctor has put it in the records for the resident that you are taking care of. It's very important. So we have already seen the blank sample, we've seen the MAR, and then we have seen activities that are also inside the MAR. So when we meet and I hand you an MAR and I tell you perform these skills, watching you to administer the medication and be able to fill it out in the MAR and show me how you fill that out. So that's going to be part of our skills that we are doing. Proper documentation is very needed. You have to know where the FL2 is for your resident and be able to understand the physician order sheet in the adult care home where you are working. You need to be able to know all that. So I was revealing, you need to know. We're going to go over it one more time. It is very important to know how to document. It is very important. You don't want anybody to be confused and not be familiar with what they're supposed to do. You have to know how to use your MAR, whether the paper MAR or the electronic. Now, whatever you see in the paper MAR, that's what you see in the electronic. So if you can do your paper MAR correctly, understand that if you work in a facility where they use the electronic, you will be able to do that as well. So the FL2, the physician's order, you will see all your patients' information, their diagnosis, what they are capable of doing, what they are not capable of doing, what medication is a routine, what are their PRNs, and anything you don't understand, you ask for clarification. If FL2 has not been signed within 24 hours of admission, verify orders with the prescribing practitioner. So when a new resident comes in, their FL2, within 24 to 48 hours, it has to be signed by the doctor or the nurse practitioner before any medication should be given out there. Always make sure that your MAR has been signed. The FL2 has been signed by the prescribing, because that's the authority that says that indeed that doctor or that nurse practitioner is the one authorizing any medication to be given. Don't just go ahead and start giving anybody anything. Even if they are complaining of headache, you want to make sure that orders have been signed first. It is very important. It is the law. Okay. So the physician's order. So they have to sign it and fax it into the facility, and it has to be kept into the resident's record. It's very important. So form onto which medication and treatment orders are transferred. All those record of staff who administered, everything has to be there. Their initials, their full name. So their full name and the initial, they have to go hand in hand. So we know that Miss Jamie Johnson, she signed her initial as well, JJ. And we know that Miss Tina House, or what? What's your last name, Mama?
Halleck.
Johnson.
Mm-hmm. So you have to put it there so that we will be able to trace it to you. Don't go and put your signature and your initials, so we don't know who signed it. We don't know who. Your name, your full name has to be there. Your initials have to be there in the MAR, so they can trace it to you and not have to come and fish for whoever did it. A licensed person prescribes or writes a medication order in a resident record. The patient's record. Is very important that they have to be the one signing on it, not the administrator, the doctor. or the nurse practitioner. They have to fax it within 24 hours. If they gave a telephone order, the med-aid has to be aware of those things. So when it comes to transcription of orders onto MAR, so transcribe means to write it down. So whether by phone or by the paper itself coming, that's what transcribe means. You want to make sure that everything, your T's, you are dotting your I's, everything has to match. The initials or the sign and the date written, everything has to be there, especially the dates. Don't forget. Any abbreviation, you can write it out completely so it doesn't create any confusion for anybody. Do not schedule PRN orders for administration at specific times. They are admitted as needed, not a routine. Count the number of dosages to be administered instead of the number of days when calculating stop dates of medications. It is very important. So, such as antibiotics. So, the doctor will tell you, how many days, will give you the date that the medication must stop. Stop date is very important. Antibiotics always have a stop date. Make sure you are going according to the stop dates. Make sure you are going according to the stop date. It's very important. A discontinued order must be obtained for an order to be discontinued. I've already said this. It's very important that if an order is discontinued, it is truly discontinued. The doctor has ordered it and it is being signed. The doctor has ordered it and is being signed. Just don't, even if they give verbal order, wait for the fax to come and discontinue it, or go according to the facility protocol. So remember, MAR should have the resident name, their room number, if applicable, facility number, if applicable, medication name, the strength of dose, the amount to be given, date and time to be given, route to be given, date of order it was written, the resident allergies. Repeat, the resident allergy is very important. It's very, very crucial. The reason why PRN medication is being given. So for headache or for fever or for cough or for constipation, it has to be. And always make sure that the MAR is kept current and accurate. It's very important. It has to be kept accurate. So we have the electronic MAR and we have the manual MAR. Some of the adult care home use the EMAR, and some also prefer to go with the paper MAR. Whichever way it is, they have to orientate you how to use a computerized MAR. It's important. We will go over, the paper stuff for FL2 and then the MAR. But if you work in a facility where they are using everything electronic, it should match. Whatever you saw in the paper should do what? It should match whatever you see in the electronic side. And always remember your 6 rights inside your MAR, that what is to be given, how much is to be given, who is it given to, when, which is the time, the route, and then the documentation is very important. All right. So we're going to end with the section F for today. We will go over this, and then tomorrow we will finish the other sections and watch the video. We will watch the video. So here is the using of the medication administration record, because we are still talking about the MAR. That's why I want to finish with the F. So you want to know, like, it's a repetition, but we want to repeat it because on the 3rd day when we meet, we want to make sure that everybody knows what they are doing. So you should be able to know what your PRNs are, your routine orders are. You should be able to know if something is out of order. Okay. If not, then you have to call the doctor and make sure it is rectified in the records. Okay. It's very important. So here is about the training of the MAR, knowing that facilities may differ, but information will never differ. The information still remains the same. Orientation at the facility, they have to go over all documentation with you before you start your career with them as a med aid. They have to go over all the FL2 document that they have and they use. Go over everything with you so you know where all the informations are. Remember all the important details. Do not ever give any medication out of memory. Always refer to your medication administration record book. MedAid uses the MAR when preparing and administering the medication. Always compare your label or the container, the drug card or the drug container. Compare the labels on it. At least do that 3 times. The first check, the second, and the third. Make sure you are doing that. Why are we doing that? Just to be safe. You are doing that to avoid med errors. If you are in doubt of anything, ask your supervisor. If you are the supervisor in charge, ask the administrator. Call the nurse, the nurse supervisor for that building. If you are working in a family care home, okay, and make sure that you are promoting safe and accurate medication administration. As we've already repeated, if you are in doubt, ask. Whenever medications are given, the MedAid will need to initial the mark under the right time and the date. That is known as the right documentation. Many medications have special instructions. Make sure you are reading these special instructions as to the dose, the time, and the route. Whatever is listed on the label, it should be matching. Okay. Plan accordingly before you start your med pass. You've used the bathroom, you've washed your hands. You are focused on what you are about to do. If the medicine says shake well before giving, shake well. If it says keep medication refrigerated, it should be in the fridge. And the fridge should have the right temperature. Always check the temperature, because when the state comes in the building, they are checking all those things. The temperature in even the kitchen fridge, the temperature of the tap waters, the temperature of the fridge where medications are kept. It is very, very crucial. Okay, have the resident drink a full glass of water with their medication, at least 8 ounces. If the medicine said on empty stomach, let them take it on empty stomach. If it says before meals, 30 minutes before meals. If it says after meals, it has to be 30 minutes after meals. If it says take it with the food, let them take it with their food. So whatever the MAR is telling you to do, that's what we are going by. If it says take it with the food, then it can be done that way. If it's saying after food, then wait for them to finish. Don't go and shove it down their throat because you are working with time and you want to crash time and go and do other things. If you say don't crash, don't do it. If the doctor has given the permission for the medicine to be crashed, then it can be put in applesauce or pudding. Always try to understand how best you can give it to your patient so they will take it. So if you know that Miss Zoe like to have chocolate pudding and they can't swallow properly, and doctor has given the okay, put their medicines in the pudding and give it to them. I know of one lady in the facility where we crashed the medications, mix it up inside chocolate shake. They call it the Ensure. Yes, most of the elderly people, they drink Ensure. So we put it in the Ensure, we put straw in it. She would drink it in a heartbeat without no. And that was the only way we could get her to take medicine. If not, no, if you're a new nurse working there and they don't tell you that trick, you will throw the medicine away that she didn't take it. It's just that somebody didn't tell you what to do. It's important to understand your residents and know how best you can get them to take their medication. So sign the MA only after observing the resident has taken. Don't do pre-charting. Don't do pre-pouring into the cups. Only when you are ready to give the medicine is when you should get it out and put it inside the cup. And sign it after, like I said, after they have taken the medication, not before they took the medicine. And make sure your initials is there, the correct day and time. Don't go and be doing omission and subtraction and addition. These are all made errors that when the state find out, it can cost you your license, because falsification comes under legal and ethical issues. The facility can fire you and they can get your license taken away from you because they want to make sure they are compliant. When residents refuse and there's any omission, document it in the MAR. It's not by force for them to take it. So if you've tried every protocol given by the facility, they still don't want to take it, you have to document it. You have to let the resident designee, whoever is in charge of their, their care, let them know if that's what their FL2 says. If he says that, call Mr. Adam about this and that, if their condition deteriorate, call, you have to make sure you are calling. Each entry must be clearly recorded, accurately and completely. And we always document with black ink, not red, not blue. Do not erase or cover errors. Don't use a whiteout in an MAR. Don't do that. Don't use a whiteout in an MAR. Don't do it. It's a big no. If the state comes in and there's crossing, like back and forth, no, don't do that. It means you are covering up for something huge, even if something little. And it's going to cause for big, long investigation that can put you on administrative leave or can get you fired and your license taken. So follow the policy for documentation, including refusals and omissions. So depending on the adult care home, PRN medication may be recorded on the same MAR or on a separate MAR. So a reason must be documented when you are doing your PRN. Okay, if you have to report 101 for fever, that's why Tylenol was given. You need to report that. So follow that policies and then make sure that you administer correctly, and then the reason, and then the effectiveness. You have to report that. Document the effectiveness of the medication when determined. The resident will need to be checked on after PRN is administered to determine the effectiveness of a PRN. If the PRN medication is reported as not effective, the Med-Aid will need to notify the supervisor and information documented. Now, one of the difference here, those that work in the skilled nursing, it is the duty of the LPN to go and do the PRN effectiveness. But in the adult care home, you as the Med-Aid, you do that. You have to document the effectiveness. So if Miss Joey said, oh, my pain is now 1, it means it is effective, because if they said their pain was 10, and after 4 hours of taking Tylenol, now it's 1, it means the medication was effective. So you need to document effective. Does it make sense?
Yes, it makes sense.
So if the resident is exhibiting pain but does not request medication or may not be able to request medication, you should be able to use that observation and based on that and do the needful. So the need for medication may be based upon resident request for the medicine or the observation. So you know that your resident cannot talk, but they are moaning in pain. You know that something is wrong. You've been with them for some time. You know the difference. So you base on your observation, then you administer the medication, and then you document when they are at peace, they are looking comfortable. So your initials and signatures, always initial and sign where it's designated for you to do so. These signatures, with your name and your title is very important. It allows for clear tracking who gave the medication. Yes, who gave it, who didn't give it. Your name is there, your initial is there, your full name is there, your initial is there, your signature is there. Okay. So they are able to see that, okay, it was done. In the court of law, they are able to prove and vindicate you that you did the right thing. So key point here is that all adult care home will have some form of documentation of medication administered, and for a place for you as the med aid to identify and put your initials. So it's important that you do so where it has been designated for you to put your initials. You do so. You follow whatever is their policy given to you. So you want to make sure that before you leave your shift, you have crossed your T's, dot your I's, check your MAR, recheck it, and make sure everything was documented appropriately. Okay, so when we meet, we will look at the handouts. We will look at it. We will look at the empty ones, and we will fill it out. Everybody will fill it out. You have fictitious names and stuff, and then you fill all those things out just so you understand. So remember, right medication, right dose, resident, right time, right route. If they refuse, put it right documentation. You put it there. All right. So we're going to touch on infection control, God willing, tomorrow. Any questions for me? Based on all the things that we have learned so far.
No, ma'am, no questions.
My only question is the handbook or the information you sent us email today is the same information that we've seen on the screen, correct?
It should follow everything we are learning.
Okay. Because the filling out of the MAR, manually.
I will print it out when we meet. You have it. I'm going to send the handout. You can also print the handout out if you want and practice it at home.
Yeah.
I'm going to email the handout to you.
Yeah, send me one too, please.
Yeah, I'm sending everybody. Everybody will have the handout. So you can print the blank, the FL2 part, and then the MAR, the blank part, print it out and
Okay.
practice on it. Practice before we meet on the third day so that everybody will pass their competency skills. When you practice at home before you come, you'll be perfect at it. And I'm going to share the Zoom recording. You can also watch it again and again, just to refresh your memory of everything we've learned today. And let me know in the next section if you have any questions. If I said something you didn't catch, and then you are watching the recording and you catch it, say, oh, she said this. I don't remember hearing it. Okay, send me the questions, and then when we meet, we will talk about your questions, every question that everybody has.
Okay.
All right.
Now,
So,
I'll meet with you on Friday, correct?
yes, I will see you on Friday, and I will see Miss Tina on Monday.
Okay. All right. But I'll see you tomorrow. That's a good thing, guys.
Yes, everybody will be on Zoom tomorrow again.
Right.
So 2 days on Zoom, and the third day is our skills, where we go over all the skills that the state requires everybody to know. So this was how we were going to do it. So everybody was going to have 5 skills done, and one person will watch what the other person will do. But since you all will not be together, everybody will go through all the skills set, because I have to have everybody do the skills for me.
Right.
So that's what is going to happen, the main skills for me. So yes, so I just want to throw that out there. I was going to split it 5-5, So one will do this and the other will do this, and everybody will watch what everybody's doing, so we could be done. But since it's going to be a split class, everybody's going to go through the full set of skills for me,
Well,
demonstrate the
thank you
full
so
set of
much for
skills for
doing
me.
that. I apologize because of Easter.
It's okay. I mean, it is what it is. We got to celebrate anyway. So thank you all so much for coming. And I'm going to see you all in the next session. Please read your manuals, read the handout when you get it, print it out, practice it. Practicing will make you perfect, and it will bring all the questions that will come into mind, so that when we meet the next session, I want all the questions to come in, so that you go out there and become the best medics they will ever have there. All right.